Without further delay, let us begin the sessions.
Before we move on, we want you to know that there are 4 sessions lined up in one set. Each session will have 3 to 4 speakers who will be speaking about the topic in brief.
Delegates, time is the key for an event to be successful, so sessions will be carried out in specific allotted time. We would like you to restrict the discussions beyond that time.
Now let's get started with our first session titled Doc I Can't Sit on Your Platter.
I would like to call the convener of the session, Dr. Ravindra Bankar, to take over the session.
Yeah, good morning. I'll start the first session now. I call upon the chair, Dr. A.R. Suresha, co-chair, Dr. Pala Manayappa, and moderator, Dr. Vishnu Bankar. And I also call Dr. Pala to introduce Dr. Manayappa. This introduction, they put it up. I think there is some confusion because they had asked for the correct of the program is I think there's no need to introduce on this and the programs. Thank you.
Good morning. I am pleased to introduce Dr. Venugopal. He is from Mysore Medical College. He did his post-graduation in last 13 years. And he is a medical director of Purna Eye Hospital, Chintamani. Special area of interest is phaco-refractive surgery and keratoconus management. May I introduce Dr. Venugopal here. Thank you. Venugopal. There are requirements for the users of the device. Damage compound, the soft gel form, which is actually maneuver, which has been confirmed as dental cavity.
somewhere somewhere and have his campus control and see the root cause.
Of a covalent bond between the collagen fibers and increasing the corneal stability. It's called free radical induced collagen cross-linking, where oxidized riboflavin and oxidized glycans also act as a free radicals. And sufficient oxygen, as we have learned from the presence of sufficient corneal stromal oxygen, is essential and primary mediator for cross-linking during the CPR procedure. In the absence of sufficient oxygen, cross-linking will stop completely. Collagen cross-linking using UV glow can be done in pellucid model degeneration, not only in keratoconus and also in pellucid model degeneration, trans model degeneration, and also post-gastric acid and also post-gastric. This is a picture comparing between normal keratoconus cornea, low magnification. In microscope, you can see the normal cornea and the flat cornea can be seen like this. This is the first with the normal cornea, electron microscope picture showing the collagen arrangement of normal cornea, corneas. Fundamental of any of procedure keep the posterior micron free away from the side of the sector. Use cross only in the anterior 3/3 micron, about 2/3 of the stone. All the current CPR devices available in the market have very small distance of about 4 millimeters. And in most of these devices, the focal plane and the implementations are defined. And they do not have any surgical integrated surgical microscope to know magnified and comfortable view, and then fluid recording demo of the actual surgeons fluid pressure is of course is high. Probability for most surgeons, so that they have to go for tentatives. This is the only flow has an microscope. So UV glow is nothing but changing the UV glow which has visible lamps to FC79 UV lamps. The advantage of UV glow is you can have very good microscopic structure view and 200 millimeters of working distance. And video recording is also possible. It's very cost effective. And you can use recording displays outside. This is the bottom view of the UV glow device. Where you can see the two UV lights, the laser beams. The two UV lights cancel the shadow effects, and the two red laser pointer beams define precise focal plane as well as the center, keeping a safe and comfortable distance of 200 mm. This is a drone made by Lifeline microscope installed by Divices Pvt Ltd. As per that, I think this can be attached in just a minute, just like Omni Glow. These are the Teflon rings we can do at multiple times. This is provided along with the mission. It is used for safeguarding the label exposure. For CPR, the total cost watch is 90 centimeters square, which can be delivered over 20 meters of time. And this is the external meter used for before doing procedure for calibration of the device. This is a console which can arrange the dosing from 30 milliwatts to 60 milliwatts. And then can given that based on the protocol of the users, it can be over the console that you can make adjustment. This is a video showing the collagen using the UV glow. Using the alcohol used alcohol one is for dilation according to 40 seconds. It has been so marathon fast. It has been watched is a movement of BSS. The field is filled out by the sponge. Everything is not removed with the log also. Cornea is also with the remote of it. Is a 1% electron. Every one drop maybe 4 minutes, 5 minutes, 30 minutes. The total of 90 milligrams or 30 volts is what the protocol suggests. So just 1 milligram exposed to the cornea. For thin corneas, you can use hypotonic solution or even a banded contact lens. We will transparent. Recently, this hypoosmolar procedure is not well because hydration, the collagen fibers are well apart. This will be increased water molecule mixtures that is more in normal. So actual procedure is less hypoosmolar. The main name of the is to protect the sun. So this is the very well put paper that are 400 to ultra-thin corneas, very useful. This is the thermogram for doing ultra-thin corneas. Even do it can be pulse with the pulse width. Very effective on a place or laser can be 1 second on and off, 5 seconds on and off, protocol. This can be developed even with TCAT using this video. So it was made in 1990. It was 50 years of the 2016. So far the new technique that are devised modern Western world takes around 18 years to become commercially available. That's the Thank you, Dr. Venugopal. Questions?
Very nice presentation. Can it be addressed only to Zeiss microscope or any other microscope?
Existing microscope.
Excellent. Customized and you can do everything in that.
Yes, sir. If we don't ask it because you can it's very nice to found that there was two laser beams. Obviously, we check it. Most of things are subjective. Somebody takes a sharp image, somebody says blur. So but this is very proper focal plane and it's excellent. I will do basic basis. After getting is very by practice. After getting at the cost of the existing device.
What's the cost?
2.5 lakhs. Less than 3 lakhs.
No, what is the excellence of paralleloplasty? This kind of. Have you come across any case with paralleloplasty following
it actually wanted to get, but never in this
the line of
and they are giving detection device along with that. But we'll be able to know the fluency of position for each and every case. And it's very safe in any other kitchen. No, how will you do propagated?
I think how are you going to feed the...
So the Teflon block that given on this device, where the various bunches. So based on the point, you can place the ring Teflon
Okay, that makes sense.
This is also available in
mono, two rings, two source of light. You can also have one source of light because some of the polyp surgeons visit various places. So the same thing cannot fit with a different microscope. So if you want, you can have monos. It gives almost the same. The only thing you can't see. Second thing, what he's saying about the customized treatment. Suppose you have a cone in the inferior region. These Teflon rings, you can cut it yourself in the specific region in which you want to treat and not the rest. Regarding the occupation which is there done in the past, you can put a larger ring or a smaller ring, so there will be a ring of exposure which will help you to do the CTR treatment on the weaker zone of the arcade. These are the things which is possible in this machine as compared to the one. Third thing is I have my own personal experience. I have the one which is about the water. And the meter which was attached to that was showing half of what is supposed to be. Then I thought of buying a new one, but before that I took this meter. When I saw it, what was supposed to be. So sometimes even the meter which is effective, you can detect with this UV meter. This UV meter is available at Amazon. It costs around 8,000 rupees. So anybody can buy it to check whether your machines are working properly or not. Before you make a judgment of that. These are the few practical things which you need to calculate.
Because we are not the life of this UV
filament is quite long. But once it goes away, you cannot replace it. Replacement of the original machine that we have is costing 5 lakh rupees. And a small LED light, not even 1,000. This is one particular thing which you can do it yourself. A lot of things which are possible and you cannot buy again. And it is made in such a way that everybody can afford to buy it.
Patient gets further surgery. One of using this.
for a year, stable, reflection and also the K-max. It should be stable for at least for a year. Reflection also should be stable.
There is something which is expected beyond this. Probably next 2 to 3 years from all over. Probably this light of source of light will be replaced with something else. It's about 10 times more effective than all this. And it can be done with the cornea of one of the background. The sound is disturbing very much. It should be really short.
Instead of UV light.
So apart from the saturation and the working distance, how comparable is it with or better efficacy-wise compared to the existing use of machines?
Equipment should be the same. Even corneas by using a fluency based on the fluency control under the one which I showed
the light that is there, the current light which is kept, the red one, it should be switched on once only. You cannot keep continuously because it needs to some amount of corneal capacity in the center. So once you focus, then you can decide the focus. Unless you want to feel that it is changed, do not keep it continuously. That is the only one switch is given. You switch on, it does not remain switch on. The moment you did it, switch on. You don't want to damage the cornea because the other way.
Last question. Elaborate
Topoguided as far as the center is concerned, I don't know about the seats. You have an inferior code. That is the portion which is most likely to be a leak. So what you do is this Teflon piece is there, which is of various rings are there. The exposed portion is from 3 millimeter onwards. So either you can put that 3 millimeter little down, hold it and continue. Or you can get a print something like that. You can customize and make you the amount of it could be left short. Opening the rest is covered with Teflon. And you put it there and then you cut it. You have to cut it. No, we can give it whatever you want. We can make it. Customize. In the weakness.
The treatment zone can be modified.
The power you are talking.
No, the treatment zone, if you want just a smaller
They are already all the rings are there with the Teflon rings are there. And secondly,
We show the rings again. The Teflon rings we will show.
even suppose the Teflon ring which is larger one, you can protect the stem cells which are around. That also is awesome. Then you can take this Teflon ring and even use the old machine.
Thank you. Dr. Venugopal. Call upon Sandeep to speak on omni-flow, stereo coaxial device to convert the basic surgical microscope to high-end.
Good morning, everybody. I am going to narrate about omni-flow by Dr. Sir and Shasta. Video narration. So omni-flow is a small detect to any of the microscope to give an excellent retroillumination. It can be fitted to, it is not only omni-flow and also it's a video flow which can be fitted to without any mount or DSLR mount in a small pocket size patchbox device. It can be projected to multiple screens. It can have a good retroillumination and also contrast and depth. Without blue, you can make an excellent axis. Can do a hydro procedure which shows a clear golden ring. With a small pupil also you can have all over retroillumination compared to the normal microscope. It not only gives retroillumination, it also gives excellent depth and contrast, which increases the surgeon's confidence. Clear differentiation between the DSS and visco can be made with the help of omni-flow. All over you can see a smiley At the end, you can have a smiley on patient side and also surgeon face. Excellent depth of view on corneal results. You can see the RBCs glowing in the corneal results. This is the contrast given by optometrist. And other advantages are with video glow you can have a laser procedure can be recorded. You can 15 mm down the opnium glow. You can see the clearly optic macula and the retina. And with opnium glow you can see the anterior retracing cavity features also while doing the surgery. And I thank Dr. Sati sir and how to come to Bhubaneswar and all my teachers and friends here. Thank you for the opportunity. Thank you.
Free of hope and is watching for the efficiency and also the quality using this only.
Does the size of pupil matter?
With small pupil also you can see the omni glow. The word itself shows omni. It is present. The glow will be present in all directions. And with small pupil also you can see the glow.
So let's say added attachments. So any change in the working distance?
Working distance remains same.
About 150 to 200 meter the distance which you can. That is not very significant. We have sufficient. Or you can change the objective lens. Sometimes when the doctor is not very comfortable, then we change the objective lens. Suppose you have 170, you can switch over to 400. And when you switch over, the new lens is electromagnetic, and that is wonderful. The old light is not happening. Last 3 years, these changes. When we replace it, we give you a lens which is much better. So that even the periphery and the center, both of them are visible. The advantage of this video system, has got a very wide field from limbus to from canthus to canthus. Every time. Even if you are doing a television, you can see very nicely. Second thing is it has got a depth of 15 meters. Which no camera has. You can see the effects of the cornea as well as. And welcome Dr. Here. You can got a 15 millimeter of depth. So you can see the effects of the cornea as well as the posterior at the same time without moving the posterior. The second thing is the camera which is used for retina is different from the anterior segment. So the posterior segment can see the anterior segment very well. Not the when you buy it, you have to think about it before you buy it.
So the amount of light also can be adjusted.
Yes, we can adjust the light. And new thing Dr. Kakade wants to make you feel. If you change your beam splitter, today most of us are using about 50 or something. If you change over from 80-20, maybe 80 will go to you. Only 20% light is enough to have a wonderful videos in this camera is NASA quality camera. And it is 1/10 of the cost. From the Sony which is also similar one, they charge 16 or 15 lakhs. 1/10 with software. The second thing is the scleral portion which is very bright. To buy the software also that can be reduced. The amount of glare which you get from the scleral part also gets reduced. The same camera you can attach to the splitter. Take it out from the ear and put it on the splitter. It's made in such a way that everybody can buy it. It's highly versatile. And we have lot of I think Dr. Kakade might be able to tell you better than me also.
I think we run the video beyond this part. So how can you use
ऑक्सीजन लगा दें.
So this is the camera which is mounted on my Lifeline. And you can see beautifully that the yard is and the video can be so well recorded. And the camera also has a mic, so you can record the voice, and the mic can be turned off if the surgeon doesn't want to record the voice, and you can turn on this is young user. You can see the clarity of the iris dust and that is dust behind the iris. Thank you.
The weight of this is only 45 grams. So those who are using the 1FR, they are scared of the whole thing falling down. It will not affect.
There's a full-length video on YouTube. Just type Dr. It's a 21 minute video which describes the entire process of entire details about the video. Because it's not only the camera. What we have done is we have dissected the camera. We have taken only the sensor on the microscope and the entire software, image enhancement and color enhancement and chromatic aberration correction. Everything is done from the software. And that is the key, because when you buy a Sony camera, even with the Sony camera, you can record videos so beautifully. Unless you buy a Sony recorder. And in the Sony recorder, they have this particular protocol which will record the camera in much better fashion than recording on a flash card. So with this camera, we definitely need a laptop or a desktop. So you have to record it on a laptop or a desktop. And the second advantage is that it has an excellent library function. So all your videos will be recorded, and then at the end of say 4 years, you have recorded 4,000 videos. And now some committee asks to present drug various cases or white matter cataract. You just have to type my white matter cataract videos, and the software will bring out those videos, those particular interests. So that is the main problem with all of us. We record, but we don't remember where it was, and when somebody asks to present, we have to fumble and spend a lot of time doing. So eventually recorders don't become present. Most of the recorders do not become liberal or proliferative presenters. So this software gives you that advantage also.
How integrated is between the device and condensing lens? After some time, it will start losing quality of the time.
No, sir. It's entirely sealed, and the entire camera goes to the base plate. There is no C-mount. So the camera between the tube and the camera, there is no space. So as long as your microscope is dust free, the camera is also dust free. But if you wish to clean, you can just open the ring, take it out, just clean it. But the sensor doesn't need to be cleaned. In case of DSLR, because there's a big opening, you might have to clean the sensor frequently. But this here, the lens and the sensor, everything is sealed, hermetically sealed. So the dust will not enter into the sensor part.
Thank you. Now I call Dr. Divices Pvt Ltd. Who's gone laser-based marker for astigmatism on axis and very and very geo. Terigo, large and soft liver PCL, blue less, and I request Dr. T.S. Gurus to kindly introduce Dr.
Morning, everyone.
I have proud privilege and honor of introducing our important guest speaker of today, Dr. Divices Pvt Ltd. He had a very brilliant academic record, and I would say that he was unique because he did, apart from MBBS and MS, he also did diploma in video engineering and electronics and LLP, all during his post-graduation. So this is something which is very unique of him. Then he plunged into solo practice in 1990 at Bhavnagar. And one of the things about his education was that his PT thesis was won the best paper prize. And that is again a great achievement. He has several firsts to his credit. For the first to formulate Viscomet we all know was a brand of viscoelastic in India, and he made it from HPMC powder for the first time in India, and that was how Viscomet was launched. And probably that was because of his short stints with David Miller, the event of MIT Boston. He is also the innovator of the first indigenized trade unit. We have a lot of trade units now, but the first one was Plantech from Ahmedabad, which he was the reason for innovation. The most important achievement of Dr. Divices is probably the one which we all use today. Most of us are using today. People who struggle with red clothes, and that is the only clothes that he has made and innovated and made life easy for us to do cataract surgeries. I think we owe a lot to him for this great contribution that he made. He has made his own homemade exam, and that too at a cost of just 40 lakhs rupees. Equipment costing more than 2 crores. He has made his own at the cost of 45 lakhs, and he's used it on his own patient. More than 4,000 patients are treated. He has done his LLP, I told you in the beginning, and the fight he had with the makers of Sol up to the Supreme Court was fought single-handedly by him without a lawyer. So this is again something very unique about Dr. And of course, co-founder Dr. Ramesh Shah has lots of lives, thousands of lives by his innovative device called Coronash, a UV light which was used along with chemical in the throat to kill the organisms, possible organisms of patients coming in contact with COVID-19 patients. So I think his hobbies are electronics and medical research. You can all imagine that. He also writes. He's a man who wears many hats, and he also writes short stories, novels. I don't know whether he has more than 24 hours. Like all of us, we have only 24 hours, but I think this man has more than 24 hours in his day. How he manages this is amazing, and has published many books which are there in the market. We are indeed privileged to have this man who has made life easy for all of us by his various innovations amidst us. Thank you. At the outset, I thank Indian Harvard Oxford Association in general and Dr. KV Satyamurthy in particular, and Dr. Vivekananda as secretary, and Dr. Satish Sheth, who has worked tirelessly and pulled all the speakers from around India for organizing this excellent evening on medical innovations. And I'm sorry I'm late because my flight last evening got cancelled by the bus, so I had to take midnight flight to Bangalore and then from Bangalore I wanted morning flight to Hooghly. So I could not sleep for the whole night. So pardon me if I am little coherent in my talks. I will first present LaserX, which is a very nice innovation which voice is what is productivity. Do you have audio clip? So I first run the video, voice, and then we will have question and answer during the discussion. I'm presenting this on behalf of Dr. Ramesh and myself. Most of the ideas which I create, the ideas get generated in his mind. Tells me that project is to be made, and since I am in a small town, and I have access to workshops and various teams, I get these ideas like so it's actually his idea which I have created. Voice.
Hello dear friends and colleagues. Today we are very happy to introduce to you Laser X. Which is a laser marker, which is a great help for toric or astigmatic keratotomy, and also for astigmatism control by on-sleep incision placing in phaco or SICS surgeries. Laser X is a prototype small slit-lamp mounted laser device having two powerful laser guns. In this prototype version 1, it is mounted on a Zeiss SL30 slit lamp, but in future it can be made to adapt to any brand model of slit lamps. With the first press of foot pedal, aiming wheels come on, and after focusing in best possible alignment at 3 and 9 o'clock position, when we press the foot pedal again, two high-power flash shots will create superficial intervals simultaneously. After numbing the proparacaine eye drops, patient is shaken on slit lamp and head is best aligned. With the other eye closed, patient is fixed on the center direct light. This direct light also works as a diffuse illuminator. After taking the patient on the Laser X slit lamp, press the foot switch and aiming wheels are powered on. Then after alignment of aiming spots at 3 and 9 o'clock position, with second press of the foot switch, laser flash shots are fired and markings are done in microseconds. This is the slow motion video of how the laser will come and create marks. Two more cases. Please note that we can make marks on limbus, fully or partly on corneal epithelium, or purely on the epithelium only, based on surgeon's personal preference. These marks last for 10 to 12 hours, so we can do these markings soon before or 6 to 10 hours before taking the patient in OT. This is how Laser X marks on table, which remain as is without vanishing throughout the surgery. Intraoperative secondary marking of ZX is done with the help of Mendes ring or Asisha's fluid marker. Marks are only superficial, just the epithelium. They are painless and they disappear in less than 24 hours without any scarring. We can mentally compare these marks to conjunctival patient by bipolar cautery, which we often do in SICS, pterygium or conjunctival surgery. We do this bipolar independence for severe and chronic keratoconjunctivitis. So there is nothing to worry about these two dots major markings. For those of us who cannot afford microvascular system, Laser X can be a good alternative, which is a much less expensive option. We have now incorporated this splitter and video camera into the Laser X module. So the same slit lamp can also be used as photo and video slit lamp. Thus the device can be 2-in-1 or just the Laser X.
Laserite is a modular device. So those of us who already have a size speed lamp, which can accept size splitter, can easily fit laserite on their own speed lamp. You may please contact us for laserite on this number. Thank you all for your kind attention.
Thank you. Some question now or? I'm sorry.
Is the laser used here?
What is the laser used here?
It's a visible blue laser.
The cost is like if you already have the street lamp, then the cost of the lamp goes out. The laser itself will cost somewhere around 1.25 lakhs. If you want to fit the camera, then another 1.25. So
With the software.
Yeah, with the software. With the capturing software.
Same camera can be used for other purposes.
Same camera can be used. No, cannot. Because the lasers are mounted on the same device. So theoretically you can dismantle the laser, then take it to the microscope and on for the surgery. But I mean, it's not that easy to mount and then realign lasers every time. So it's better to have dedicated there.
Sir, this is reference model 0180.
Right.
Suppose we use some other tool lenses where we have to make the axis mark. Is it possible to rotate it and then do the mark on the
Yeah, that's true. So we actually first made a rotatable device with an axis mark. I'll show that also. But the problem with that was that when the patient has more than 45-degree marking, we have to put speculum because we don't have the 12 o'clock and the 6 o'clock position exposed. So we have to put the speculum and then mark it. So that was becoming a tedious thing. Plus, when you rotate the laser, after 10-15 times, the alignment might go. So every time you have to learn to realign it on a calibration target. So after that experience, we thought that this is much simpler and much better to have it at 0 and 180. Once you have got the 0 and 180 reference, you can just mark the secondary axis or the desired axis on table with a ink marker.
The question is, see, suppose you create a software where we can just repeat the axis.
But that adds to another device on your microscope. And large television in the OT and the cost of that software is another 2.5 lakhs also. But that can be combined. But
instead of going through that too complicated software route, much easier. We have used this in more than 4,000 patients by now. And we find it so simple. Once you have 0.1 reference, it's so easy to find the desired axis.
Some of the street lamp already has these grids on the software. I think one Chinese made Kangowa, they have this grid which is there. If you are doing 180 marking, this is on the screen. You can see where the 145 degrees are there. If you remember a little bit, you can do the same thing. One more thing which I want to tell you, that the marker which we have made in both of us has got two parallel lines, something which is metallic one, which will negate the parallels between the two lines. That is the only one which has got parallels negating system for the Turing marker. So that becomes extremely accurate as compared to the other one.
And we are happy to present for the first time zero recurrence surgery with bandage contact special bandage contact very go. Pterigo is the Latin word is the wing that is how the pterygium takes the name. This is a pterygium goes forever. And this is using a 21 scleral bandage contact lens, where we don't need to use nor blood nor fragment patients or plasma, nothing. So let's see surgical video. I think skip slides all these common steps of removing the pterygium head and dissecting the body, which we all are familiar with, most of us are seniors. And cleansing the pterygium head, wrapping up the epithelium, unscraping of the debris and the residual material from the cornea. Gentle bipolar contraction, measuring the desired flap, marking the flap and dissecting donor conjunctival area with the luminous stem cells. Cutting out the flap. Washing the flap and then inverting the upside down and putting it here. Now we don't use fibrin glue. A lot of nothing. Just put the flap there. And give an acupressure kind of therapy to the flap. Give it 20 points. And then just for a minute. And in 1 minute the flap develop a reasonably good adherence. And you can test the adherence by water test. You flush gently and the flap will not move. That flap will develop vacuum. It will be heavy to see to. Now, if the flap is not stuck, if you are not rated for a minute or so, it will move like this with the water. So it's just a water test. Once the water test is positive, flap is stuck. And after the flap has stuck, this is the soft 21 mm soft bandage contact lens, which is impregnated with nanosilver particles. It's really lens we need or hands or assistant assist in putting it. So once you put the flap, once you put the BCL there, covers, and then you put antibiotic drops. And even with the bandage lens, you can nurse the flap so well. This is UV light. You can see the margin of the bandage contact lens. Remove out the speculum. I usually give crack and patch for it. I always remove the towel under the microscope under my visa so that I know that everything remains secret without moving. And then I give a tape and a pad at least for 6 hours, 4 to 6 hours. Now this is the second demo stop on slit lamp. Sorry, it's not the second. This is the second demo stop on slit lamp. And after we remove the BCL, on the slit lamp after putting empirical electrodes. You can see that the graph is taken up so very well. Eventually it will come as a strike, so this can just fill out and use it as a manual. There are advantages that it covers the donor side, it covers the recipient side, as well as covers the denuded epithelium of the cornea. The patient doesn't feel any forward sensation, any discomfort in this lens. So that is the main advantage. And surgery is just 5 to 7 minutes, at the most 10 minutes. So the cost of everything goes out. At the moment, the best type is almost 40,000 rupees. Whereas this lens costs much lesser than that. And many times you use the cheaper fabric glue, it has a lot of allergenicity. So it causes edema in the flap. Sometimes the gap in the flap. So with the pressure all around the glacial, the flap does not shrink, does not have ecchymosis or fluid collection under the flap. It remains flat as is. जैसे रखा है वैसे ही रहेगा पूरे साल तक. So that's another advantage. Cost of the suture is also out. 10 almost 900 rupees now. We call it as cut paste and cover technique of the region. Free of regime and standard of care. The protocol remains same. There is nothing extraordinary to be done. I usually use 12 hours patch, and then from the next day the patient starts using oxygen drop and oral NSAID or as long as he needs and oral multivitamin. But that's the surgeon's preference. There's nothing special due to the lens. Now another advantage found with this contact lens when we started using this with the UV globe for C3R, that this contact lens, because it has a hole in the center, so in case of keratoconus patient, when I put this lens, it clears the entire cylinder and all the astigmatism, irregular astigmatism. So whatever is the residual refractive spherical error, that only the patient has to wear. Then we asked the company that can we make this with the power? So they said yes, we can make the power. So we put the plane on as a trial lens in the keratoconus patient and then refract the patient and let us say the patient is -2.5. Then the company can make the same lens with -2.5 power, so that patient can start using. And the reason is excellent. The patient was so happy. And because it's a large lens, it does not fall, and gas permeability is 2%. So it has the highest value. FDA approved, the material is US approved, kept in for 4 months continuously. So we asked the patient to take out once in a week or so, but theoretically we keep it for 4 months. And the FDA says 4 months is actually 8 months. So without neovascular evaluation, this can be kept for a very long time. So this is an excellent option for the keratoconus patient. And the cost between the DCL and the power is really funny. You ask me one question, it's power can be made from +30 to -30. So it's a big range. So any reflection is covered. The value is much more than its price. And we found other indications was when the patient has 32 or 16 RK done, and the central cornea is so flat that the patient has a very high later age, or with regular astigmatism, much higher order aberrations. So we put this PCL on these patients. It excellent result for these keratoconus patients and post-RK patients. In both groups, this lens can be used, the powered one. First the planar one, and then find out the power and order for the powered one. And there is always, because of the gold, there is always a reservoir of 100 to 150 micron. And when the patient drinks, when the patient drinks this apex portion, this apex portion gets pressed. So the reservoir fluid goes out. When the patient opens the eye, again lens goes back to the wall. So every time there is continuous exchange of the tear film under the lens. So the corneal nutrition does not get suffered. So it's kind of a dynamic reservoir. Other indication we found was chronic intractable filament. There are patients who have filaments recurrent, and those patients work very well. Chronic recurrent epithelial erosions. In case of bullous scattergoss, those patients do not dissecting surgery, just BCL, and because of the pressure of BCL, all the surface irregularities goes away, the bullous pain goes away, the vision improves significantly. Other indication is the spheroidal corneal disease. There also there is so many surface irregularities. Put the lens, make the surface perfect. The image quality on the retina improves so much. This is another indication in which I use whenever I do the left. And since this is a big lens, sometimes the air bubble goes in. So don't worry about the air bubble. Leave it there. The moment it heats up, the air gets burnt out from the 12 o'clock position. So even if a large or small air bubble is there, while putting the lens, you don't need to worry, just leave it there. This can also be used for SLAT. Of course, most of us do not do SLAT, but if you are doing SLAT, instead of using membrane graft, you can just put the seeds of the stem cell, put the BCL on it, and you don't need amniotic membrane. So I think this number you wish to have, and a few lenses are brought, and one of you wish to have, you can have. So thank you very much for presentation. It can be made from 40 mm to 21 mm as per the surgeon desires. For the pterygium, we need 21 to 22 mm because if we take a big graft, we cover right up to the medial cancer. That's fine. But for the therapeutic indication, for the smaller, it can be very small. So 14, 16, 18, 20, 21 and 22, all these diameters are possible.
These lenses are treated like nano.
I'm sorry. Yeah. It's when the lens button is formed, nanosilver particles are impregnated into it. So it has its own preservative. And the nanosilver is stimulant for surface regeneration. Like UV moist eye drops. The UV moist eye drops, they come with nanosilver particles as the preservative. They don't use them as the preservative. Yes, I see. Stop.
Sir,
in case of adenovirus, you want to use the hepatitis virus involvement of the cornea. Day one.
We do the OCT, it has not gone into the
remove everything and put this bandage contact lens.
The recovery is so good that I don't need any antiviral drugs. We have done about 4 patients. And all four of them, so one patient was chronic palpitation, which has come from UV for the last 6 months. She has only been counting, removed epithelium completely, PCA for 4-5 days. The whole epithelium got covered. She improved to 680. So Adenovirus and other viral infections of the cornea. It is restricted only to the epithelium, not gone to the bone. The best way to remove the completely reduce the load and put this contact. Second thing what he said is regarding the keratoconus. I have three patients that were for last 3 months. And the first patient, all three of them done with the CPR. And all of them have 636 and 624 vision on 4 cylinders and spectrums. The openings came with a lot of aberrations. Lot of other things were there. We put in ACM last 3 months. All of them were improved from 636, 618 to 69. Cylinder portion is almost disappeared. The sample the spherical which we were accepting 3 spherical 4 cylinders has come down to 1.5 spectrum. But the quality of vision and vision is not so good. Last 3 months we have not even touched the lenses. I'm expecting them to come back after 1 month and see what happens. But what is a wonderful thing, wonderful design. It helps our corneal blindness, partial blindness, whatever you say. Cover at an affordable cost. The basic idea of both of us that whatever we do it should be affordable to all of us. That is the basic concept. We want to earn for ourselves, not for the companies.
So what's and this for the keratoconus patient, either we can train them to put this large lens by themselves in a vacuum cup. Or it can become a 4-monthly visit to your clinic and you can just remove it. Yes, ma'am.
So one question, do you check the base curve, do a keratometry, check the base curve and then order the lens?
No.
For keratoconus?
No. This one has a base curve which is above the average. And it has a fairly good bolt. So if you go by the base curve, it will touch the cornea. And there will not be that fluid reservoir. And when it touches the cornea, the cylinder and the higher pressure will not be negative.
So only the reflection. You don't have to do any other color.
No, first thing is you take the BCL, put it on the eye of the patient and let it be for 1 day. Next day you refract the patient. And then whatever is the best accepted spherical power, that much power you order for the patient.
Amazing, absolutely amazing.
Yes, sir. There is something for fungal also. I think Dr. Jagdeep might be able to tell you. He's asking about why don't we go to fungal also of the cornea. We have a Lifeline.
We both have working present on green light device. Rose Bengal stain is very readily absorbed by the cornea. So we can make the Rose Bengal ourselves soaking 2 Rose Bengal strips in cyanide, which will make it as 0.1% solution. So you use this as a photosensitizer and then expose these to 5 to 2 nanometer green light for 10 to 12 minutes. All the bacteria would die. So that is our next innovation, which is already rated as green glow. And even we can do corneal collagen crossing. So if the time permits, I show the uses of that green glow at the end of the session. But I mean, it's like a PDT, photodynamic therapy for the corneal infection. You don't need to wait 21 days for the fungus to die of oral keratoconus.
I treated 2 patients with keratoconus. 400 micron was the thickness of the cornea. 62 was the stiffened keratitis. And in less than 1 month, from 62 it came down to 53. That much we used 10 times more branding and the tightening effect on the. Ultimately, we are expecting that these blue light probably will be replaced with the green. The one thing which I have seen. I have seen one very poor experience when I did for the first time. We requested one company to make the solution of rose pepper. And
we told him to do specific, and there was some error in making it. And the cornea was stained. The whole cornea had become a lavender color. For 1 month, and I was so scared that he does not know I had it. In 1 month's time, he assured me that it was dying. That same patient has improved so much. Finger counting, it becomes 680. Extremely happy. Most important is less than 400 microns we can use. The CPR with the green light. I think one of the sightseeing case has been reported in this case here with the green light along the surface.
Since the talk is on, let me show you 4 or 5 beams of it. Please, so this is the green device, which is again a photodynamic. Any therapy wherein light photons, especially wavelength, are used, which will be absorbed by a specific chemical, biologically compatible chemical, which will convert the photonic energy into electronic energy and destroy the microorganism or induce some change known as photodynamic therapy. So essentially, CPR is also a photodynamic therapy. Like we used to have the macular photodynamic therapy. So this is again a photodynamic therapy for the corneal infections. We are still not ready for the marketable, so not to present it at the moment, but since the matter has come up present. So this is see the green light is absorbed by the red color. We know that it's the opposite of each other. Green in our trial we have green lens and then we have the red lens, and we put both together. Nothing. So the same the rose bengal is perfect absorption for 532 nanometer photons. And it gets absorbed in first 200 microns of cornea. We can prepare it very simply. Just autoclave 4 strips of rose bengal in the drum and dissolve the 4 strips of rose bengal into 5 ml of BSS. And that will give us approximately 6 milligram of rose bengal dye, 5 ml of BSS. That will be 12% collagen cross-linking. Instead of doing UV light, this gives 11x corneal softening versus 6x in UV-C3. It gives more than double flattening. So we get almost 4 diopters of flattening at corneal plane. That is almost 6 diopters of myopia reduction at the spectacle plane. And the treatment time is much shorter, 10 times for soaking, 10 minutes for soaking and 10 minutes for treatment. And the total procedure time is about 20 minutes. And the rose bengal and green light both are absolutely safe for corneal endothelium, iris as well as for retina and blood aqueous barrier. There is no haze induced at all. There is no initial corneal thinning because there is no keratocite test or apoptosis. Because when we treat the cornea with UV light, the keratocytes in the exposed area all die. As a result of the cornea initially will become thin by about 20 microns. And that also induces the haze. And it takes about 8 to 10 or 12 months for the peripheral keratocytes to come and repopulate the central area to clear the cornea to come back to the thickness. Whereas when we do this with the green light, it does not happen. So at the moment, we have two US University and one Chinese university, we are working on this. And looks like that in years' time, this should be approved by the Indian FDA and available for India. So these are the references and another interesting thing as an extension to Dr. Gopal's talk. There is another group who is doing very good research, purely chemical cross-linking. Liverpool University of UK, Taiwan University of Taipei, Arvind Eye Hospital and Oral Lab of Madurai together are also working on purely chemical, not photodynamic, but just chemical cross-linking. So after a decade or so, after full FDA clearance, the time may come when we have to use only some eye drops 4 times a day for a week or so to induce chemical cross-linking and treat the corneas. And purely chemical cross-linking by using beta-nitro alcohol and zenipene. These are the two liquids. Cornea for arresting keratocytes, etc. Anterior scleral for scleromalacia, and posterior scleral for halting progression of the pathological myopia. I am pretty sure after having studied that pathological myopia, progressing myopia, will have this as the final treatment. Just one terrible injection of zenipene and beta-nitro alcohol. Sclera becomes 6 hours myopia stops. So this is going to be the future in another 5-7 years. So yeah, see, UV C3R was developed by Dr. Seiler as early as 1998, but it got the FDA approval in 2016. So for any new technique, drug or device, modern Western science world, it takes 18 to 20 years to become approved and commercially available. So this might take some time, but I'm pretty sure that Green is going to give us a wonderful tool to treat corneal infections from the surgical process, not medical process.
Thank you, sir. Listen to the audience.
And so particular dimensions.
Can you repeat the question for all?
Of the BCL? See, you do white-to-white measurement, and then you do the canthus to canthus measurement. And you give it to us, and we will make the lens best fit the patient. Because many patients who have small cornea but large, there are many patients who have large cornea but small sclera. So we need to distinguish white-to-white and canthus to canthus for the treatment lenses. What is the cost of the lens? The cost of the lens is 2,000 rupees plus GST. If you buy 20 as a lot, this is the I'm talking about the plano for the treatment. If you buy 20 lens, you will get 5 or 6 free. So the effective cost will be 1,600 rupees. And for the therapeutic treatment lenses with the power, we have to add 100 rupees for every 10 diopters. So like you need up to -9, then it will be 2,100. But if you need 11, then it will be 200. But it's not a big difference. So yes. It is 2% more retaining content. So in fact, it has a much better advantage. It retains the drug so well. So we asked to put the mouse and ketronic and top of the contact. Percolates fluid. And also from the side. Because the tear film is dynamically changing every time. Not necessarily, but if the patient is going to be allergic to preservative, it's better to have preservative because the contact itself has preservative. So we really don't need the preservative.
Sir, green glow, what is the duration to be for fungal keratitis?
Can you use the microscope, microphone, everybody?
What will be the exposure time for green glow for the fungal keratitis? Right. So that see, we are studying this. We still don't have absolute nomogram at present. But the main fact is that if the cornea is too opaque, or if the infection is too deep, then we have to give a longer exposure time. It's like cloudy day, the sunlight will not reach very efficiently on the surface of the earth. So in that case, you need a longer exposure. The cornea is little clear, then you just need 7 to 8 minutes of exposure. Again, that depends what brightness you keep. So we usually keep 80,000 lux. And 80,000 lux is equivalent to 3 milliwatts of power. So when we really come out with this, we will have the nomogram. Then the picture, if you have this much depth, you see on the camera, you can judge that the fungal infection is 200 microns being obtained, all when you do an anti-segment OC, and we come to know that this is the depth. Then that much exposure can be given. Second thing will be, the base technique we have is that even if you underexpose, much of infection load is in 10 minutes. Then the antifungal drugs work much better, much faster. So what will take 25 days will take on 4 days to resolve with this exposure. So this may not be an absolute treatment, may not be a complete replacement, but this could be an excellent adjunct.
See, you reduce the corneal opacity 1, destruction of the corneal tissue 2, and one more thing, I think we have forgotten, you have to remove the epithelium from all the cornea. You have to remove the epithelium when you do this procedure, even in fungal ulcer. So there is a clear cornea on the side, you definitely remove the cornea.
Yeah, we have to remove the epithelium, otherwise the ulcer has to be first scraped out, the stuff has to be removed, because otherwise the rose bengal will not penetrate efficiently. The light can go through, because it's a visible green light. The light can theoretically go through the light, where the epithelium itself is being absorbed, so we will not allow light to pass through. So green light will not worry about. And
what is the soaking time? How long should they keep the rose bengal?
10 minutes. 10 minutes. See, riboflavin, which is contained in 20% extra, is very thick. It takes very long to percolate by the gravity. It takes almost 30 minutes before you can see the fluorescence in the anterior chamber, the mild fluorescence. Whereas rose bengal is a dye. It's very fluidy. So I and Dr. Reddy at Sankara, we are working on this, and we have tried almost all. And bacterial infections, they get killed instantly. The fungal infection takes another 4 or 5 days. But it works very fine. It really works. Best thing for practicing. And then can we use regular what we use for retinal lasers? No, use the laser. The laser is coherent, you can go right on the retina. We don't have to use the coherent light, we have to use the incoherent light. So not green, and the spot size is very small. It will be a broad spot, 10 millimeter diameter, cover the entire part. For that you have to fire the laser, even if you protect the retina, you have to fire the laser at so many spots. Then that's unnecessarily wasting the resource of the laser head. So no, it's a simple thing. And if I use the laser, it's too expensive. These not cost more than 80,000 rupees. And the rose bengal will not cost more than 10 rupees. 4 strips. 2.5 kg.
There is a focusing system which is similar to what the UV system has been. There is a 2 laser light which you can focus in the green light properly. There is a focusing system attached to it.
And we have to have a photon meter. You put the photon so you know how many milliwatts the green light is giving. Because lamps when they are new, they will give you very bright as they go old. You might have to increase the power on the. So every time you first measure, and there will be a table showing 80,000 lux, then you expose for 10 minutes, showing 70,000 lux, expose for 11 minutes, like that. So at the focal point, light only. You can consider these only. So it will get attached to the microscope. So microscope working distance is the working distance of this. And laser, there will be 2 redly pointed lasers will come from 2 sides. So where the spots they match, that is the focal plane. So that is where you use the meter and measure the power. And then you bring the patient, bring the microscope on the patient.
How about in the advanced ulcer thinning case? It's safe.
The green light does not induce any thinning. Like the UV light induces thinning. It does not induce the thinning. And one of the research says that this prevents the collagenolisis. Green light in rose Bengal has an additional property that prevents collagenolisis. You can just go on Google and type rose Bengal green light therapy, photodynamic therapy for corneal infection, and you will get all the multiple publications. The Bascom Farmer Institute of Florida and Hillside Hospital already have worked a lot on this. And Hansen University in China has worked a lot on this. So we collaborated with these three groups and we tried indigenous.
In case of
No, it's a green light. And the cornea is not transparent. And the exposure is also 10 seconds. It's a pure visible green light.
even if you see the digital mapping which is 3 and 4 shows the same pattern what the UV light. Epithelium is supposed to cover. Whether it is a keratoconus or any other disease, irregularity tries to cover. You see the comparison maps before 1 month, 2 months, 3 months, 6 months, 8 months.
The same measure on corneas with UV light.
Thank you, sir.
Thank you very much.
One more thing which I found out from his talk in the use of silver, which he started and I took that thing very seriously about 4 years back. And that was what silver at 35,000 to 90,000 today.
Satish.
Thank you, doctors, for your enlightening words of wisdom.
Now, I would like to request Dr. Banakar sir.
Hello.
Thank you for having invited me, especially to the Hubli Ophthalmic Association. And let me introduce. I am from T. Ravindra. I take care of cataract and glaucoma. My interest has been in this for more than 20 years. And what I did here as irrigating blade because of the problems is often faced during surgery. Like water we have done, may sometimes be not successful in objectively meeting our needs. These are some of the outcomes we expect. But the difficulties that we have to undergo during the surgery may be many.
This is a situation where conjunctiva is bleeding. We can't do much of cautery. And how to go about the situation at this stage. A good assistant may be required and may not be present at that time. Is it possible to take all the things into our control rather than depending on the assistant? This is the assistant's. So we do preventive cautery to the bleeding vessels and minor irrigation, but each of these methods got their own strengths and limitations. So what we did is that using simple things in our day-to-day life, these are the tying mechanism, these are the things available from our OT, this is the IV bottle. Once we connect all these things, we get the connection from the IV bottle and the blade that is doing the surgery is getting irrigated. And then when the blade itself is irrigated, sometimes the fluid will be more, and so we will need aspiration also. And from where do we get the aspiration? We can use the aspiration from the phaco machine. By including the simple Lifeline that we use for the IV cannula and disconnecting it and connecting to the phaco machine. So aspirating Lifeline coming into the field by tactfully and skillfully handling the instrument. So this is the circuit that we demonstrate. There is a recurrent surgery requirement. Retinal detachment surgery has been done. Is very thin and attached quickly. We can do cautery, but with this mechanism we are able to do the dissection and very clean dissection has been possible. The buckle is there and we have to place the tube body has been placed, but here comes the need for suturing, and when we have to do the suturing, the bleeding is coming as a distraction. How to manage this? We try once, we try 2 times. Getting the right nick is important. Predicting the position of the eyelet of the valve is important. But bleeding is going on continuously. This can be prevented by preoperative thing, but sometimes in spite of all the preventive preoperative mechanisms, we may not be successful. So here we get the aspiration module made from the 22 gauge pen flung. The assistant is holding it at the right place and we are able to find the eyelid. This is the phaco machine coming into our use for the glaucoma surgery.
Once again, that step is being shown where the aspiration is used. When doing the suture for the fixing of the tube body. The tube here is going to go into the pars plana and the vitreous. So that was the end of the surgery. Actually what we have done is that we have started using this mechanism even in our glaucoma surgeries, and we don't have to use the cautery, and we are conducting a trial where we want to see whether this has got any advantage over use of cautery, so that if cautery is going to cause some chemotaxis and those factors, this may also cause some factors, but what is the balance, what is the advantage of this method over the other conventional method? So once the results come out, I will, I think, make all of us aware of those results also. Thank you, sir. Patent also for this, and the application may be going forward.
Thank you, sir. Any questions?
Now we invite Dr. Jagdeep Kakadia sir to present the Traboclean mechanism, a novel ultrasound device in the management of glaucoma.
कंटिन्यू कर लीजिए और कॉन्वर्सेशन लगे तो तुम्ही जाकर स्टार्ट होगा
Hello dear friend. Hello dear friends and colleagues. Here it is therapy.
Thank you so much, Dr. Ravindran, and I'm so happy to introduce Traboclean to you on behalf of Dr. Donald Schwartz, a very leading and well-known surgeon, glaucoma surgeon in USA, and Dr. Mesha and myself. Will you respect?
Hello dear friend. It is therapeutic ultrasound for glaucoma for saving sight with sound. DUG is originally the concept of Dr. Donald Schwartz, who is a senior prolific cataract surgeon in Long Beach, California in USA. Don is Clinical Professor Emeritus of Ophthalmology, who received Best Doctor of USA Award in 2003. He is past Director of American Academy of Ophthalmology, American Board of Ophthalmology, and past President of California Association of Ophthalmology. And we have a lucky opportunity to work with Dr. Donald Schwartz in last 12 years. It is a well-known and well-documented fact that ultrasound phacoemulsification lowers the intraocular pressure. We also know that harder and bigger the cataract, more is the IOP lowering effect. Is it only due to deepening of the anterior chamber and widening of AC angle? Then why not this happens in cases of sutured ECC or SICS? So Dr. Donald thought it was probably due to ultrasound energy. Spray of the stray ultrasonic energy is actually cleaning the trabecular meshwork by ab interno approach because of the sonomechanical vibrations. While giving 30-watt energy at phacotip, we are unknowingly also giving 3-watt energy to opposite one quadrant of trabecular meshwork. Ultrasound is also known to trigger a cytokine cascade, which ultimately leads to a significant reduction in intraocular pressure. Cytokine cascade effect induced by ultrasound is exactly same as that induced by slit-lamp laser trabeculoplasty. So we thought that if ab interno ultrasound in OT can lower intraocular pressure, can we achieve it by non-invasive ab externo approach in OPD or as an office procedure? So we designed a handpiece and a console to deliver low intensity focused ultrasound of 3-watt power of 40 kHz frequency to the trabecular meshwork as well as to the canal of Schlemm by an ab externo non-invasive approach. This is how the current working prototype looks like, which weighs less than 2 kilos. There is a console, there is a foot switch, and there is a handpiece. After confirming the safety of repeated procedure in rabbit model in vivo animal studies, we started humanized in vivo studies. Traboclean is as good as cleaning a blocked tea strainer by sonomechanical vibrations as well as by induction of cytokine cascade, which is analogous to SLT. In fact, SLT only has cytokine pathway, whereas Traboclean has sonic vibration pathway as well. In this video, we can see gentle and focused ultrasonic vibrations, which are so mild that we can hold and stop the tip, which is impossible in case of phacotip, which has 10 to 12 times higher ultrasonic power. The Traboclean TUG treatment is non-invasive OPD or office procedure which can be easily performed under topical anesthesia. After insertion of the speculum, the eye is marked at 4 cardinal points around the limbus. 2% lignocaine gel will work as anesthetic as well as ultrasound contact gel for better transmission of the sonic energy. Limbal spot treatments are to be given for 60 seconds at each clock hour position. We can give 4 spots, 8 spots, or 12 spots. Let us see a video of Traboclean procedure. Traboclean probe tip can be disinfected with any hand sanitizer, or it can be covered by a cutout of a little finger of our surgical gloves. We start at any one of the marked spot, apply the tip to the limbus just behind the cornea without much pressure, just a gentle apposition with enough methyl visco or anesthetic gel in front of the tip, which will be the conductive medium of ultrasound. Hold the tip for 1 minute, time being measured by an assistant seen on wall clock or phone stopwatch. Just remember, 1 minute at one spot. After 1 minute at one spot, when over, we move on to the next spot. This way we can give up to 12 spots in one single sitting. One spot of treatment approx gives us 3 mm IOP reduction. 5 to 15 minutes is the total duration of TUG treatment, and this medication-free IOP reduction and control will last for approx 6 to 8 months. This is the comparison of number of spots versus pharmacological equivalence of the IOP lowering effect. In last 13 years, over 900 patients are treated with over 12,000 post-treatment examinations. 50% fall of IOP is measurable in 6 hours after the TUG treatment. In 24 hours, IOP is fully down as per the number of spots. Trabecular meshwork cleansing effect lasts for 6 to 8 months in more than 94% of cases. We give repeat TUG treatment every 6 to 8 months, and it can be repeated as many times as needed for the lifetime of the patient. When we treat the second eye, the first treated eye shows approx 25% further reduction of IOP. So treating 2 eyes separately at an interval of 7 days is more beneficial. This is due to cytokines going to other eye through blood circulation. The dictum is treat the worst eye first. For named PONG patients, we treat directly. For patients on topical drugs, if we know their virgin IOP max, we treat TUG by n number of spots and stop all medications from that day onwards. For those patients who are on medications in whom we don't know what is their max IOP, then we stop all medications, allow a washout period, measure IOP max, and then treat with TUG for n number of spots accordingly. Best and longer lasting TUG results are found in pseudoaffected patients. Very mild discomfort without any pain just for 1 day is the only post-op symptom. Mild redness and very mild aqueous flare just for 1 day are only post-op signs. Topical or systemic NSAID or steroids are not to be given because we do not want to suppress the cytokine cascade. They are not even needed. No topical medications are needed anymore, and all are to be stopped soon after TUG treatment is done. And when medications are stopped, all associated symptoms such as dryness, redness, and lead dermatitis are quickly resolved. Post-TUG, within a week or so, eye and patient start to feel and look so happy and healthy. Compared to SLT, Trevoclean gives 20% more IOP reduction. This is the publication about Trevoclean TUG. Ultrasound stimulation on uveal tissue is known to induce long-term secretion of mTOR. mTOR is an enzyme fully named as mammalian target of rapamycin. mTOR is known to induce the regeneration of optic nerve and spinal cord. Activated mTOR induces and enhances retinal ganglion cell regeneration and rejuvenation. We can drive neural regeneration through mTOR cascade. Trevoclean TUG activates mTOR pathway, which leads to retinal ganglion cell regeneration, which not only holds the progression but actually reverses the glaucoma and the field changes. After 2 TUG treatments in 1 year, the RNFL thickness is increased from 0.099 to 0.202. This is another case in which in 13 months after 2 TUG treatment, the RNFL thickness has increased from 0.021 to 0.160. As the RNFL thickness increases, cuffs get filled, so the CD ratio decreases from 0.79 to 0.57 in this case. There are hundreds of patients in whom significant increase in mean RNFL thickness is noted in 12 months after 2 6-monthly TUG treatments. Corresponding improvements are also seen and documented in visual fields. In this case, without any topical medications, in right eye, mean deviation has improved from -8.89 decibel to -6.29 decibel, and PSD has improved from 6.31 to 3.27 decibel in 12 months after 2 TUG treatment. In same patient's left eye, the mean deviation has improved from -15.63 to -10.97, and PSD has improved from 9.84 to 6.96 decibel. This is a one-eyed advanced glaucoma patient who has improved significantly in 6 months with just 1 TUG treatment. We can see that visual field index has improved from 33% to 55%. Mean deviation has improved from -21.12 to -17.25, and PSD has improved from 6.59 to 10.20 decibel. This visual field shows improvement in mean deviation from -12.77 to -7.33 in 12 months after 2 TUG treatment in right eye of the patient number 21. In same patient's left eye, mean deviation improved from -11.4 to -10.21 after 2 TUG treatment in 12 months. One more case of visual field improvement. Trabocline TUG is probably the only non-invasive, non-pharmac glaucoma therapy which can not only hold the progression of glaucoma but which can potentially reverse it. Trabocline TUG is a double-armed sonic sister of the single-armed slit-lamp laser trabeculoplasty, which is easier, portable, there is no learning curve, and is lot cheaper than the SLT. Here is a caveat: TUG is effective and indicated only in open-angle glaucomas, primary or pseudophakic, but it is contraindicated in narrow-angle glaucomas of all types. A specially made solid and ball-tipped phaco needle for TUG is a novel concept developed by Dr. Mukesh Dolakia, which can be used with our own phaco machines without the need for a special console. After marking 6 spots on a hemicircle of limbus, phaco is applied on each spot for 1 minute using 2% xylocaine jelly as conduction medium, and phaco power is to be kept at 5% on the phaco machine console. Thank you very much for your patient listening.
Excellent talk, sir. Now we invite Dr. Satish Sheikh for his talk on OmniFlow. Let Me Flow, a new generation glaucoma drainage device into the retrovalvular space. We will have questions on these sessions later on in the day.
Abhishek has completed his MBBS from Kasturba Medical College, Bangalore, and has completed his MS from RIU Minto, followed by his fellowship in Global Eye Hospital, Bangalore. Currently, he is the director of Drishti Eye Hospital and Research Center, Vidyanagar, Hubli, as well as associate professor in ophthalmology in KIMS, Hubli. He has established Drishti Eye Foundation, presented multiple papers, videos in state, national and international conferences. He has received Dr. M.M. Joshi Overall Best Paper Award, Best Video Award in COSCON, Best Innovation Video Award and the Best Video Award in an ISM-SICS World Conference 2017, Second Best Innovation Award and Video Award Anti-Race segment in AIOS and ISM-SICS. He was the first recipient of Dr. Rohit Shetty Best Research Award, COSCON 2019. The Innovation CME, he has multiple innovations in his bouquet too. He has developed techniques for pterygium and corneal ulcer treatment and is the founder of Innovision Medical Optics. So we are really privileged to have you with us, sir. Over to you.
And suck the water, but when capillary is hydrophobic, it will repel the water back. Hydrophobic capillary valve tube made of Teflon will resist the aqueous humor passage, maintaining a minimum back pressure of 10 mm and is much smaller than the Ahmed glaucoma valve. This is observed well in retinal surgeries. Even large scleral buckles are almost free from fibrosis and can be easily removed even after years or decades, just as if a hair is being pulled from butter. Retrobulbar space can easily drain up to 500 microliters per minute without engorgement, proptosis or chemosis. Aqueous humor production and outflow discharge rate is only 3 microliters per minute. Hence, retrobulbar space can easily drain 170 times more fluid than the aqueous humor production. Omniflow's supplied tube length is 50 mm. Needed length is between 30 and 40 mm. Axial length plus 5 mm is the ideal and enough length to reach retrobulbar space without touching the optic nerve head, without folding, kinking or overcrowding the retrobulbar space. Let us see few videos of Omniflow. The tube is primed with 27 gauge cannula and primed with BSS. And as we can notice that the discharge of the aqueous humor is proportionate to the pressure which we create in the syringe. With low pressure, there will be no drops falling. With high pressure, there will be a jagged stream of aqueous coming out, and with medium pressure, only drops will be coming out. After putting L cut in the conjunctiva and after a little blunt dissection, insert a vectis to reach the retrobulbar space, which is very easy. We can insert almost 40 mm of vectis which goes into the retrobulbar space and creates a track. A gentle bipolar cautery is done. Now we make one scleral tunnel which is made by angled MPR 20 gauge, 7 mm away from the limbus at 45-degree angle. The tunnel is now lubricated with viscomethyl. The beveled end of Omniflow is now inserted in and passed through the scleral tunnel, entered into the anterior chamber, bisecting the angle between the endothelium and the iris. The beveled end of the tube is now inserted into the anterior chamber via the second scleral tunnel. Only the bevel goes into the anterior chamber about a millimeter or 2, maximum 2 millimeters. Then the excess bend of the tube is pulled back, and which is then pushed back into the retrobulbar space. The firm anchoring of the tube is confirmed by vigorous pull, push and side. Choroidal effusions, never. Hypertonic maculopathy, never. Omniflow can be implanted in phakic eyes also, if the chamber depth is good enough. This is an interesting case of traumatic subluxation of crystalline lens with angle recession glaucoma. The tube got blocked by incarceration of prolapsed vitreous strands. Vitrectomy relieved the tubal blockage, intraocular pressure came down, and so the mydriatic pupil also became smaller. Post-RD surgery silicone oil-induced glaucomas are extremely difficult to treat and are really intractable because of total blockage of collector channels by emulsified silicone oil spherules embedment. Omniflow can cure such glaucomas even after 2-3 failed trabeculectomies. Omniflow is the procedure of choice in neovascular uveotic glaucomas. In this one-eyed young patient of severe Sturge-Weber syndrome, after 4 failed traps, Omniflow saved the only working eye. Tube is biointegrable, so there is no need for any patch, scleral or corneal or pericardial. Antimetabolites are not needed in most cases. Except this grooved tube holding forceps, no additional surgical armamentarium is needed. IOP between 10 and T and a deep anterior chamber are always well maintained. Thank you very much for your kind attention. Hello dear friends and colleagues, we are very happy to introduce to you Omni.
Yeah, I wish to inform this audience that this video won the Best Video Award in the anterior segment in AIOS coaching, which I received in Kolkata last month. So we'll better take the questions because we are running short of time. So we'll move on to the next topic. One more topic is there. Suprachoroidal.
Omniflow suppression for severe intractable glaucoma, which is a new method of using a tube for choroid as the drainage system, being presented by none other than Dr. Jagdeep Kagadia.
We acknowledge immense contributions from Dr. Ankush Mahajan and Dr. Satish Shet. Omniflow Supra is a suprachoroidal tube shunt for BAGS, BAGS, that is bleb-free ab externa glaucoma surgery. It is a very useful procedure for very severe, intractable, refractory, recurrent, oily, bloody, all types of bad glaucomas. Suprachoroidal space was first described by the great Dr. Fuchs of Vienna in 1980. It is an avascular and real space between outer surface of choroid and inner surface of sclera, which is most often visible on OCT also. It is perpetually filled with aqueous humor-like thin fluid, which is about 35 to 50 micron in thickness, having a total volume of 1000 to 1500 microliters depending on eyeball size, with immense resorption and drainage capacity. The choroid, having a fairly large surface area, is active in resorption of aqueous humor. Hence, a patient having RD will almost always have low IOP, usually under 10 millimeters of mercury. Based on these facts, Leopold Hein introduced operation of cyclodialysis for glaucoma as early as 1905. From 1905 to 1965, cyclodialysis was the only procedure for severe glaucomas. It was abandoned when trabeculectomy took the main stage because cyclodialysis was associated with severe hypertony, usually around 2 to 3 millimeters of mercury, with all complications associated with hypertony below 6 millimeters of mercury. Having learnt a lot about tubes, shunts and setons from Dr. Daniel LaRoche of New York and Dr. Martin Ahmed of USA, we developed Omniflow Supra
which is a 15 mm long silicon tube having a pressure and outflow regulation micromechanism fitted inside the lumen of this tiny tube. Now let us see the surgery of Omniflow Supra step by step. This is a case of a 70 years old one-eyed gentleman having an anterior chamber IOL with severe uveitic glaucoma with virgin IOP around 80 millimeters of mercury, and with maximum 4+ oral medication the IOP was around 45 and the vision was PL+. First, we have to make a fornix based interval flap about 6 by 6 millimeters in size. Now we do gentle and mild wet-filled bipolar cautery, just enough to give us clean and bloodless field. Technically, this is not a must. Now, using a 300 to 350 micron depth-guarded diamond or metal disposable knife, we make scleral grooves to create a trapdoor scleral flap of approx 5 by 5 millimeter in size. Then, using a crescent or hockey tunnel making knife, we create a lamellar scleral flap which is hinged on limbus. We now mark a spot 2 mm behind the limbus, and from there we enter the anterior chamber with 23 gauge angled MBR. Entry can be made between cornea and iris or in eyes with in-the-bag PC IOL, preferably between iris and the capsular bag. 2 mm behind that entry spot, or total 4 mm behind the limbus, we now make a scleral scratch incision to expose the suprachoroidal space. Don't worry, this is a real space and it is really avascular. It's not going to bleed, and choroid is so compact and so pliable structure that it is almost impossible to damage it. Please make sure that we have to use only the crescent tunnel dissector knife of FACO or MSIC as incision, or we can use number 15 BP knife. Please do not use sharp pointed entry knife or MBR blade for this step. Except for this Omniflow tube holding forceps, no additional surgical armamentarium is needed. Even if it is not there, Colibri or Hoskins forceps will work reasonably well. Any one end of the tube has to be cut into a shape of a bevel by Westcott or tenotomy scissors. It's a platinum cured soft silicone, so it cuts like a butter slice. With the Omniflow tube grasping forceps, we now insert the tube in the tunnel and enter it into anterior chamber only about 1 mm inside. And as soon as the tube is in, IOP will come down. Please notice the controlled release and slow flow of aqueous humor. After cutting out the excess length, we can now insert the rear end of the tube into the suprachoroidal space. Please don't worry at all. This is very easy and a completely atraumatic step. Tube goes in as easily as a candle in cake. We can safely move the tube little back and forth to adjust the length. Suprachoroidal space is a real potential space which is really very safe. It is analogous to pleural, pericardial, subdural or epidural space, and it is safe for injections, cannulations and temporary or permanent catheterizations. We can mentally compare this space with leeches. Now, we anchor the tube to scleral bed with 90
or 10-0 prolonged suture. In the return bite, it is safe to transfix the tube via its body and or its lumen. Don't worry, it will not leak because it will get tightly closed around the suture. The transfixation is necessary to prevent its forward or backward migration in future with the eyeball movement or with the rubbing of the patient's eyelids. This is an essential step. Transfix or lumen of the tube, either way is okay. Transfixation suture can be placed in this fashion also. We can leave the scleral flap unsutured, or we can suture just two corners with 10-0 vacuole. Then the conjunctival flap is pulled back down to limbus and is anchored to sclera at two corners with 10-0 vacuole sutures, keeping the ends long, which are buried under the conjunctival flap. IOP came down from 80 to 08 mm immediately. After 1 week, it was 14 mm without medications, and it remains around 9 millimeters with just timolol 1 drop HS. And vision from only PL improved to 6/24 part. Patient as well as surgeon with their entire families are very, very happy. For the patient, it was like Tamsoma Jyotirgamaya and Jyoti Kalash Chalke in the literal and verbatim sense. Almost all patients done so far had excellent IOP reduction, which is maintained so far over 18 plus months because suprachoroidal omniflow has the hypotony advantages of accidental cyclodialysis and or fragmentogenous RD without any of the disadvantages of them. Essentially speaking, it is a controlled, valve tube, irreversible microcyclodialysis. Antimetabolites are not needed and are never to be used. To avoid future possible corneal endothelial cell loss, as far as possible, we preferably insert the tube behind the iris and in front of capsular bag complex. Since this is a bleb-free surgery, the tube can be placed in temporal or inferotemporal site also, especially in cases of multiple failed and scarred grafts. Not only dedicated glaucoma surgeons, but any one of us can easily perform omniflow surgery. This is how the omniflow tube is packed in ETO sterile double pouch. Omniflow is Indian FDA registered. In near future, it will be available commercially from Excel Optics Private Limited, Chennai. And yes, we do have a small financial interest in Omniflow. With Omniflow, each one of us can become a warrior in the fight for sight. We'll be happy to answer your questions. Thank you very much for your kind attention.
Thank you very much, sir. Dr. Ravindra, I'll be taking your role slightly for a minute because now we are going to present the video of the surgery that we had performed in KIMS, Hubli, just about 3 weeks ago. So I welcome you, Dr. Padma Shri Dr. M.M. Joshi, sir. So he's going to be inaugurating this function as today. And we have with us Dr. S.F. Kamar. He is an orthopedic surgeon and current director of KIMS Hubli. He happens to be my PUC classmate, so it is a proud moment for us that he will be the guest of honor for today's function. And it is under his regime that now we are able to operate this case, because when there was a previous management, I was not allowed to operate because we were not having the FDA approval. So when I wanted to do this surgery, I was not permitted to do this in KIMS Hubli. So I had to take this patient outside in a private setup and operate free of cost. And follow-up was still done in KIMS Hubli. and now we are seeing a sea change since it is FDA approved now, and we can procure these glaucoma devices in KIMS in future under the leadership of Dr. Kamali. So after this we'll break for tea, and then we'll come back for inauguration session. There has been no voiceover in this because it is still unedited video. So this surgery was recorded also in KIMS only when the surgery was being performed. So we didn't have access to wet fit cautery. So we converted a cottonless common, no, not common sense also, uncommonly common. I don't know why they call it as common sense. It is not common, that's right. So we are in a very compromised situation in KIMS, probably because we are not having all the ultra high gadgets what other private practitioners enjoy. But within the limited resources, we have tried to achieve the best. No accolades for that, but at least I need appreciation that an institute like KIMS in a government center in Hubli, which is a Tier 2 city in Karnataka, we are able to perform these kind of surgeries. So we had simultaneously done cataract as well as glaucoma surgery. Now at least we have got access to portable IOLs, phaco machine over the last 7 to 8 years. So it was an SICS done, and still we implanted a foldable IOL with a smaller incision. So this surgery, this is first in Karnataka, into the suprachoroidal space and the glaucoma shunt also. And third surgery in India after Kakadia sir and Dr. Ankush Mahal. IOP was 30, he was not on any medication. Other eye had retinal detachment, and this was his only seeing eye. He was a farmer. So there is a community by name Siddhi. They are the African descendants of the slaves who were brought down from Europe, from Africa. And that's how they escaped the British regime, and they were located in different locations in India. So there is a place called Kiruvati, which is just about 40 kilometers from Hubli. So there you have this native population with African descent. So he is a farmer by occupation, 70-year-old man, 30 millimeters mercury with no medications. So after the surgery, the pressure has come to first 7 millimeters, and now it is stabilized at 10 millimeters. Vision of PL plus, now improved to counting finger close to face. So now his children have informed our postgraduates that he is able to see the food on his platter, he is able to walk in his room without any help. So this was the first time that I entered the suprachoroidal space, because we had nothing to lose, because the patient was PL positive, and we had already intimated the relatives that PL may disappear. So for which they agreed. We took a special consent for that, and that's how we could perform this surgery. So actually we can fast forward, but I don't want to interrupt in between. So just another 2 minutes, please. So we were compromised in many situations. We wanted even the suture also. We wanted something like Prolin, but we didn't have that. We had 9091. We used that 9091 to anchor the suture. So entering into the anchor chamber is very, very easy. If you just have one MBR knife, you can simply directly enter the anchor chamber. And if it is an aphakic eye, you can as well go behind the iris also. If you are able to do combined surgery of IOL plus glaucoma shunt, you can directly enter the behind the iris, so that by any chance if the stent is there, it will not be touching the endothelium and you will not end up with any corneal decompensation. So this suturing technique also was again discussed with Kakadia sir on the day of surgery. So he had taken a bite, a reverse bite. So whereas I took anchoring at 2 points next to the tube, so I anchored it to the sclera. The same knot went through and through the tube, and we sutured the tube. So this is the first time ever I have entered the suprachoroidal space. So far it was the domain of retinal surgeons. Dr. Guru Prasad will be definitely able to highlight on that. So we were so scared. So I was told that it might bleed. Don't go and don't do anything in suprachoroidal space. Then we searched the literature. We did not find anything which caused bleed following glaucoma shunt or anything by an aerodialysis claim. So we went ahead with this surgery. Surgery was a success.
No, Satish, just one small question. It's a simple tube, silicon tube, and where is the control?
Control is at the back, and it is at the back.
It's not a simple tube.
It's not a simple tube. It is not a simple tube. It has got unilateral flow. It doesn't flow reverse.
If you can imagine a thermometer, the old mercury type thermometer which we used to put in the mouth, right? There used to be a constriction So once the mercury goes this way, it's not possible for the mercury to go back unless you do it like this. So it's the same way. This tube is not a simple tube. It has a pyloric valve-like structure inside the tube. So that pyloric valve again is flexible. So if the pressure goes above 10, that pyloric valve, imagine the pyloric valve inside the tube, will expand a little, allow a gush of few drops, and the moment the pressure is 10, it will close. So it's not a simple silicone tube. Thank you, sir.
Because otherwise the suprachoroidal drainage,
Otherwise, the suprachoroidal drainage is so much that the IOP will remain around 2-3. It will not come above 2-3, and that will lead to kissing choroids and macular fold and all the hypertonic complications. That's the reason why the cyclodialysis procedure was abandoned, because of the chronic, non-manageable chronic hypertonic. So what we did was taking the advantage of RD without having the disadvantage of RD, taking the advantage of cyclodialysis without having it, because the tube controls the pressure. Thanks.
Can audio be heard? So his name is Allah Sahab from Kirwati. And we had recorded his video on a mobile. I'm just asking him, like, if you give consent for the surgery and if you are afraid, will you go back to your fields and will you work? He was very, very enthusiastic. He said, if I'm able to see my flock and if I'm able to go to my fields, there is nothing like that for the rest of my life. Thank you so much. Thank you.
Here we come to the end of the wonderful session. We move on to the inaugural procession. Now it will be debrief.
Thank you, doctors, for creating awareness on new glaucoma treatment options.
Now I request Dr. Ravindra sir to give token of appreciation to all the dignitaries. Dr. Sharad Kolvekar. Dr. Tanushree Hegman. Dr. Anita Mayappan. Now I request Dr. M.M. Joshi sir to give token of appreciation to Dr. Ravi. Thank you, sir. Let us begin the inauguration session.
I would like to call Deepthi Joshi ma'am on the stage.
ಅನೌನ್ಸ್ ಮಾಡ ಸತೀಶ್ ಹೇಳ ಇದು
ಕರ್ನಾಟಕ ಆಫ್ಥಾಲ್ಮಿಕ್ ಸೊಸೈಟಿ ವೈಸ್ ಪ್ರೆಸಿಡೆಂಟ್ ಆಗಿರುವ ಡಾಕ್ಟರ್ ಶಿವರಾಮ್ ಸರ್ ಅನ್ನು ನಾವು ವೇದಿಕೆಯ ಮೇಲೆ ಬರಮಾಡಿಕೊಳ್ತೀವಿ. ದೇವರನ್ನು ನೆನೆದು ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ವಿದ್ಯುತ್ ಚಾಲನೆ ನೀಡಿದ ಡಾಕ್ಟರ್ ಟೆಂಟು ಹಾಗೂ ಶ್ರೀ ವಿದ್ಯಾರವರಿಗೆ ಧನ್ಯವಾದಗಳು. ದೀಪ ಬೆಳಗೋಣ, ಧನ್ಯತೆಯ ಭಾವದೊಳು ದೇವರನ್ನ ಬೇಡುತ್ತಾ ತಮೋಗ್ನರಾಗೋಣ. ಈಗ ವೇದಿಕೆಯ ಮೇಲೆ ಆಸೀನರಾಗಿರುವ ಗಣ್ಯರಿಂದ ದೀಪವನ್ನು ಬೆಳಗುವುದರ ಮೂಲಕ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಚಾಲನೆಯನ್ನು ನೀಡಬೇಕೆಂದು ವಿನಂತಿಸಿಕೊಳ್ಳುತ್ತೇವೆ. I call upon Dr. Vivekanand Jivanji sir, Nilin Kalyanji sir, Dr. Tharushila ma'am, Dr. Ramesh Shah sir, Dr. Jamdeep Kakadia sir, Dr. Vikrant Phale, Dr. Anuga Herur, Dr. Satish Sheth as well as Dr. Srinivas Joshi to kindly join the Lifeline ceremony. ನಮ್ಮೆಲ್ಲರ ಮಾರ್ಗದರ್ಶನ ಬೆಳಕಾಗಿರುವ ನಮ್ಮ ಹಿರಿಯ ನೇತೃತಜ್ಞರಾಗಿರುವ ಡಾಕ್ಟರ್ ಎಂ ಜೋಶಿ ಸರ್ ಅವರಿಗೆ ಪುಷ್ಪಗುಚ್ಛ ಮೂಲಕ ನಾವು ಸ್ವಾಗತ ಕೋರುತ್ತೇವೆ. ನಮ್ಮ ಗೌರವ ಅತಿಥಿಗಳಾಗಿರುವ ಕಿಂಗ್ಸ್ ಡೈರೆಕ್ಟರ್ ಡಾಕ್ಟರ್ ಎಸ್ ಕಮ್ಮಾರ್ ಸರ್ ಅವರಿಗೆ ಪುಷ್ಪಗುಚ್ಛೆಯ ಮೂಲಕ ಸ್ವಾಗತ ಕೋರುತ್ತೇವೆ. ಈ ಸಮ್ಮೇಳನ ಇವತ್ತು ಹಲವಾರು ಆವಿಷ್ಕಾರಿಗಳು ಆಗಮಿಸಿರುವುದು ನಮ್ಮೆಲ್ಲರ ಸೌಭಾಗ್ಯ. ಆದರೆ ಒಂದು ಆವಿಷ್ಕಾರಿ, ಖ್ಯಾತ ನೇತೃತಜ್ಞರಾಗಿದ್ದ ಡಾಕ್ಟರ್ ವಿಕ್ರಮ್ ಥಳಿವಾಲ್ ಅವರು ಇಂದು ನಮ್ಮೊಂದಿಗಿಲ್ಲ. ಅವರ ಬಗ್ಗೆ 3 ಮಾತಾಡಬೇಕೆಂದು ಡಾಕ್ಟರ್ ಸತೀಶ್ ಶೇಟ್ ಅವರನ್ನು ಕೋರಿಕೊಳ್ಳುತ್ತೇನೆ.
ಧನ್ಯವಾದಗಳು ಡಾಕ್ಟರ್ ದೀಪ್ತಿ ಜೋಶಿ. ನನಗೆ ಕನ್ನಡದಲ್ಲಿ ನಿರೂಪಣೆ ಮಾಡಲಿಕ್ಕೆ ಬರೋದಿಲ್ಲ, ಬಟ್ ಕನ್ನಡದಲ್ಲಿ ಡಿಬೇಟ್ ಮಾಡಿದ್ದೇನೆ. ಕೃಷ್ಣ ಪ್ರಸಾದ್ ಅವರು ಇಲ್ಲಿದ್ದಾರೆ. 2011ರಲ್ಲಿ ನಿಮ್ಯಾನ್ಸ್ ಬೆಂಗಳೂರಲ್ಲಿ ಅದು ಒಂದು ಡಿಬೇಟ್ ನಡೆದಿತ್ತು. ಯಾರೋ ಹಿಂದಿನವರು ಕನ್ನಡದಲ್ಲಿ ಮಾಡಿದ್ರು ಅಂತ ನಾನು ಕನ್ನಡದಲ್ಲಿ ಮಾಡಿಬಿಟ್ಟೆ. ಬಟ್ ಆಮೇಲೆ ಹೇಳಿದ್ರು, ನೀವು ಕನ್ನಡದಲ್ಲಿ ಚೆನ್ನಾಗಿ ಮಾತಾಡ್ತೀಯಲ್ಲ, ಮಾತಾಡೋದಿಲ್ಲ ಯಾಕೆ ಅಂತ. ಯಾಕಂದ್ರೆ ನಾನು ಕನ್ನಡ ಶಾಲೆಯಲ್ಲಿ ಕಲ್ತಿರಲಿಲ್ಲ. ಹಾಗಾಗಿ ನನಗೆ ಅದು ಏನಂತೇವ ಸ್ಟಟರ್ ಅದು ಮುಂದೆ ಮಾತು ಬರೋದಿಲ್ಲ. ಸೊ ಈಗ ವಿಕ್ರಮ್ ಥಳಿವಾಲ್ ಬಗ್ಗೆ ನಾನು ಹೇಳಬೇಕಾಗಿತ್ತಂದರೆ, ಸೊ ಅದಕ್ಕೂ ಕೂಡ ಒಂದು ಕಾರಣಾಂತರವಾಗಿ ಒಂದು ವಿಷಯ ಇದೆ. ಸೊ 2019ರಲ್ಲಿ ನಾವು ಇಂದೋರ್ನಲ್ಲಿ ಆಲ್ ಇಂಡಿಯಾ ಕಾನ್ಫರೆನ್ಸ್ ಅಟೆಂಡ್ ಆಗಿದ್ವಿ. ಆಗ ನಾನು ಅವ್ರ ಜೊತೆ ಸುಮಾರು ಒಂದು ಅರ್ಧ ಗಂಟೆ ಬರ್ತಿದ್ದೆ, ಮಾತಾಡ್ತಾ ಇದ್ವಿ, ಏನೇನು ಆವಿಷ್ಕಾರಗಳನ್ನು ಮಾಡ್ತಾ ಇದ್ದೆ ಅಂತ ಮಾತಾಡಿದ್ದೆ ಅವ್ರ ಜೊತೆ ನಾನು. ಸೊ ಅಲ್ಲಿಂದ ನಾನು ವಾಪಸ್ ಹುಬ್ಳಿಗೆ ಬಂದೆ. 15-20 ದಿವಸದೊಳಗೆ ಮಧ್ಯಾಹ್ನ 3:30 ಗಂಟೆಗೆ ಕೃಷ್ಣ ಪ್ರಸಾದ್ ಅವ್ರ ಫೋನ್ ಬಂದು ನನಗೆ. ಹುಬ್ಬಳ್ಳಿನಲ್ಲಿ ಕೃಷ್ಣ ಪ್ರಸಾದ್ ನನಗೆ ಯಾಕೆ ಫೋನ್ ಮಾಡಿದ್ರು ನನಗೆ ಇನ್ನೂ ಅರ್ಥ ಆಗ್ತಾ ಇಲ್ಲ. ಆದರೆ ಅವ್ರು ಫೋನ್ ಮಾಡೋ ಸಮಯದಲ್ಲಿ ನಾನು ಗೂಗಲ್ನಲ್ಲಿ, ಯೂಟ್ಯೂಬ್ನಲ್ಲಿ ವಿಕ್ರಮ್ ಥಳಿವಾಲ್ದು 3D ವಿಡಿಯೋ ನೋಡ್ತಾ ಇದ್ದೆ. ಐ ಡೋಂಟ್ ನೋ ಇನ್ ವಾಟ್ ವೇ ಹಿ ವಾಸ್ ಟ್ರೈಂಗ್ ಟು ಕನೆಕ್ಟ್ ವಿತ್ ಮಿ. ಆ್ಯಂಡ್ ವೈ ಕೃಷ್ಣ ಪ್ರಸಾದ್ ಕಾಲ್ಡ್ ಮೀ, ಐ ಸ್ಟಿಲ್ ಡು ನಾಟ್ ನೋ ಟಿಲ್ ದಿಸ್ ಡೇ. ಆ್ಯಂಡ್ ಐ ಸ್ಪೋಕ್ ಟು ಡಾಕ್ಟರ್ ಸೀನಿಯರ್ ಥಳಿವಾಲ್. This is what happened. He said, what time was it? It was somewhere around 3:30 in the afternoon. So Krishna Prasad has called me around 4 o'clock and he was immortalized at around 3:30 in the afternoon in Nabha. So I don't know. There is something beyond my imagination. So I spoke to Thaliwal sir. Sir, we want to have you here in Hubli because we are doing a CME on bouquet of innovations. And I cannot think of any other innovator other than Nanhe. They used to call it Nanhe. So Kumar Vikram Singh Thaliwal. So we then decided to name this hall as Dr. Vikram Singh Thaliwal Ballroom for today by, say, the Hubli Dharwad Ophthalmic Association and Dr. Satyamurthy. The moment I talked to him about this, he immediately consented. And to fill in the lacunae for that particular period was, say, Dr. Krishna Prasad Kutlu, the KOS president, whom we were planning to felicitate today. He declined at the last minute, and permission was given by Dr. Satyamurthy, and I utilized that time now to pay tribute to Dr. Vikram Singh Thaliwal. So I just read out his brief CV, which Senior Dr. Thaliwal has shared with me. So he was a budding young ophthalmologist from Punjab, a manual small incision cataract surgeon par excellence, equally at ease with phaco, and took pride in being popular in his area as an oculoplastic surgeon. He obtained his diploma in ophthalmology from M&J Western Regional Institute of Ophthalmology, BJ Medical College, Ahmedabad, India. He was a diplomat of National Board from Eye Care Eye Hospital and Postgraduate Institute, Noida, India. He was practicing ophthalmologist, eye formary, Nabha, for 6 years, 4 months and 20 days. Precise timing has been noted by his father till date. He authored the chapter Manual Small Incision Cataract Surgery, an update in the book Ready Reckoner for Modern Cataract Surgery. Co-authored the chapter Temporal Manual SICS in the book Master's Guide to Manual Small Incision Cataract Surgery, as well as 2 chapters on slit lamp examination and specular microscopy in Cornea Illustrated, a guide to clinical diagnosis. In 2018, Vikram was the editor-in-chief of the e-book Master's Guide to Manual SICS, which was released at the World Ophthalmological Conference, Barcelona. He has contributed as an author to 3 books and has more than 35 publications. He was just 33 then. Instruction courses, workshops, national and international level to his credit. So his surgical videos can be seen at YouTube channel. So we'll share the YouTube channel link to all the delegates who are present here in this conference. He was the editor of Journal of ISM-SICS and monthly video journal of ISM-SICS. He was the projects manager and consultant eye surgeon of Eye Foundation Nabha, which organizes a weekly free eye clinic for poor patients, providing free consultancy, free medicines, free eye surgery since 1997 under the aegis of Eye Foundation Nabha. He was instrumental in arranging and operating more than 25 free eye camps in and around Patiala district of Punjab, now which has been carried forward by his aged father, who is not operating anymore, but he has got his friends who are continuing his same services free of cost. He can be remembered in person at Eye Infirmary Nabha, and he has got a Facebook link which we'll be sharing with you later. Thank you so much.
ಧನ್ಯವಾದಗಳು ಸರ್. ಮಧ್ಯ ಕರ್ನಾಟಕದ ಈ ನಗರಿ, ಬೆಣ್ಣೆ ದೋಸೆ ಇಲ್ಲಿ ಗರಿಗರಿ. ಇಂಥ ಸೊಗಸಾದ ದಾವಣಗೆರೆಯಿಂದ ನಮ್ಮೊಂದಿಗೆ ಶ್ರೇಷ್ಠ ನೇತೃತಜ್ಞರಾದ ಡಾಕ್ಟರ್ ಬಣಕರ್ ಸರ್ ಅವರಿಗೆ HDOA ವತಿಯಿಂದ ಈಗ ಒಂದು ಸನ್ಮಾನ ಕಾರ್ಯಕ್ರಮ. ಇದನ್ನು ನಡೆಸಿಕೊಳ್ಳೋದಕ್ಕೆ ನಾನು ಡಾಕ್ಟರ್ ಸಂಜೀವ್ ಕುಲಕರ್ಣಿ ಅವರಿಗೆ ಬರಮಾಡಿಕೊಳ್ತೇನೆ.
Let me introduce our own Dr. Ravindra Banka. He completed his MBBS from JJM Medical College, Davangere, Mysore University in 1992. Obtained post-graduation in MS Ophthalmology in 1995. Worked as a resident at Sri Devaraj Aras Medical College, Kola, before joining JJM Medical College as a lecturer in 1996. Currently serving as professor and in community service, particularly in diabetic retinopathy education for rural diabetic patients. Conducted research on community-based diabetic retinopathy screening. Organized several eye camps on eye donation awareness and free cataract surgeries for school children. Has been postgraduate guide for several years. Served as the youngest secretary and later as president of the Indian Medical Association Davangere branch. Associated with the Rajiv Gandhi University Health Sciences, Bangalore for nearly 2 decades in various roles such as Senate member, syndicate member and member of Academic Council. Currently a Senate member elect and the only member elected 5 times in the Senate in RGUHS. Married to Dr. Mangala GK, who is a professor in the Department of Microbiology. He is blessed with 2 sons. Thus I present to you Dr. Ravindra Banka.
ಮೆಕ್ಯಾನಿಕಲ್ ಸೊಸೈಟಿಯ ವೈಸ್ ಪ್ರೆಸಿಡೆಂಟ್ ಆಗಿರುವ ನಮ್ಮೆಲ್ಲರ ಹೆಮ್ಮೆಯ ಡಾಕ್ಟರ್ ಶಿವರಾಮ್ ಸರ್ ಅವರಿಗೆ ಈಗೊಂದು ಸಣ್ಣ ಸನ್ಮಾನ ಕಾರ್ಯಕ್ರಮ.
ಶಿವರಾಮ್ ಸರ್ಗೆ ಇಂಟ್ರೊಡಕ್ಷನ್ ಅಗತ್ಯ ಇಲ್ಲ, ಯಾಕಂದರೆ ಹಿ ಈಸ್ ಎ ಮೆಂಬರ್ ಆಫ್ HDOE. ಈಗಾಗಲೇ ಅವರಿಗೆ 2 ಸತಿ ಸನ್ಮಾನ ಆಗಿದೆ. 3ನೇ ಸತಿ ಮಾಡಬೇಡ, ನನಗೆ ಮುಜುಗರ ಆಗ್ತದೆ ಅಂತ ಹೇಳ್ತಾ ಇದ್ರು. ಈಗ ನಾವು ಆಲ್ರೆಡಿ 2 ಟೋಪಿ ತಂದಾಗಿತ್ತು, ಗುಡ್ಡೋರು ಬರಲಿಲ್ಲ. 2ನೇ ಟೋಪಿ ಇನ್ನೊಬ್ರಿಗೆ ಹಾಕಬೇಕಾಗಿತ್ತು, ಅದಕ್ಕೆ ಅವ್ರಿಗೆ ಹಾಕ್ತೇವೆ.
ಈಗ ನಮ್ಮ AIOS ARC ಮೆಂಬರ್ ಆಗಿರುವ ಡಾಕ್ಟರ್ ಶ್ರೀನಿವಾಸ್ ಜೋಶಿ ಅವರಿಗೆ ಹೂಗುಚ್ಚಾರ್ಪಣೆ. ಹಾಗೂ ಈ ಕಾರ್ಯಕ್ರಮದ ಬೆನ್ನೆಲುಬಾಗಿರುವ ಡಾಕ್ಟರ್ ಸತೀಶ್ ಶೇಟ್ ಅವರಿಗೆ ಹೂಗುಚ್ಚಾರ್ಪಣೆ. ನಮ್ಮ ಹುಬ್ಬಳ್ಳಿ ಧಾರವಾಡದ ಹೆಮ್ಮೆಯಾಗಿರುವ ಹಿಮ್ಸ್ನ ನಿರ್ದೇಶಕರಾಗಿರುವ ಹಾಗೂ ಇವತ್ತಿನ ಕಾರ್ಯಕ್ರಮದ ಗೌರವಾತಿಥಿಯಾಗಿರುವ ಡಾಕ್ಟರ್ SF ಕಮ್ಮಾರ್ ಸರ್ ಅವರಿಗೆ ಇಂದಿನ ನಮ್ಮ ಈ ಕಾರ್ಯಕ್ರಮ ಕುರಿತು ಮಾತಾಡಬೇಕಂತ ವಿನಂತಿಸಿಕೊಳ್ಳುತ್ತೇನೆ.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಸತೀಶ್ ಶೇಟ್ ಹೇಳಿದಂಗೆ ನಾನು ಕನ್ನಡದಲ್ಲೇ ಮಾತಾಡಲಿಕ್ಕೆ ಪ್ರಯತ್ನ ಮಾಡುತ್ತೇನೆ. ಯಾಕಂದರೆ ನಾನು 1ರಿಂದ 10th ಸರ್ಕಾರಿ ಶಾಲೆಯಲ್ಲಿ ಗೌರ್ಮೆಂಟ್ ಸ್ಕೂಲಲ್ಲಿ ಓದಿದ್ದೆ. ಸೊ ಇವತ್ತಿನ ಈ ಒಂದು CME ಆಪ್ಥಾಲ್ಮಿಕ್ ಕಾನ್ಫರೆನ್ಸ್ ಇದರ ಸಲುವಾಗಿ ಬಂದಂಥ ರೆಸ್ಪೆಕ್ಟೆಡ್ ಅವರ ಚೀಫ್ ಗೆಸ್ಟ್ ಪದ್ಮಶ್ರೀ ಶ್ರೀ MM ಜೋಶಿ ಸರ್ ಅವರೇ, ಡಾಕ್ಟರ್ ಶಿವರಾಮ್ ಅವರೇ, ಡಾಕ್ಟರ್ ಬಣಕಾರ್ ಸರ್ ಅವರೇ, ಡಾಕ್ಟರ್ ಸತ್ಯಮೂರ್ತಿ ಅವರೇ, ಮತ್ತು ಎಲ್ಲ ಇಲ್ಲಿ ಡೆಲಿಗೇಟ್ಸು ಮತ್ತು ಫ್ಯಾಕಲ್ಟಿ ಮತ್ತು ಬೇರೆ ಸ್ಟೇಟಿಂದ ಬಂದಂಥ ಗೆಸ್ಟ್ ಸ್ಪೀಕರ್ಸು ಮತ್ತು ನಡೆದಂಥ ನಮ್ಮ ನೆಚ್ಚಿನ ಸ್ನಾತಕೋತ್ತರ ವಿದ್ಯಾರ್ಥಿಗಳೇ ಮತ್ತು other invitees who are present in this August occasion. So first of all, I wish and I warm wishes from my institute, that is Karnataka Institute of Medical Science, Hubli. Earlier it was known as KMC, Karnataka Medical College, Hubli. ಯಾಕೆಂದರೆ ನಾನು ಇಲ್ಲಿ ಬಂದಾಗ ಅನ್ನಿಸ್ತು, ನಾನೆಲ್ಲ ಇಲ್ಲಿ KMC ಫ್ರೆಂಡ್ಸು, ನಮ್ಮ ಸೀನಿಯರ್ಸು ಜೂನಿಯರ್ಸ್ ಎಲ್ಲ ಸಿಕ್ಕಾಗ KMC ರಿಯೂನಿಯನ್ ಆಗ್ತಾ ಇದೇನೋ ಅಂತ ನನಗಿಲ್ಲಿ ಅನ್ನಿಸ್ತು. ಯಾಕೆಂದರೆ ಮೋಸ್ಟ್ ಆಫ್ ದ ಡೆಲಿಗೇಟ್ಸ್, ಫ್ಯಾಕಲ್ಟೀಸ್ ಆ್ಯಂಡ್ ಫ್ರಮ್ ಸ್ಟೇಟ್ ಆಸ್ ವೆಲ್ ಆಸ್ ಡಿಫ್ರೆಂಟ್ ಸ್ಟೇಟ್, ದೇ ಹ್ಯಾವ್ ಐದರ್ MBBS ಗ್ರ್ಯಾಜುಯೇಷನ್ ಆರ್ ಪೋಸ್ಟ್ ಗ್ರ್ಯಾಜುಯೇಷನ್ ದೇ ಹ್ಯಾವ್ ಡನ್ ಫ್ರಮ್ ದ KMC. ನೌ ಇಟ್ ಈಸ್ KIMS. ಸೊ ನನಗೆ ಭಾಳ ಹೆಮ್ಮೆ ಅನ್ನಿಸ್ತೈತೆ. ಯಾಕಂದರೆ ಡಾಕ್ಟರ್ ಸತೀಶ್ ಶೇಟ್ ಇರ್ಬೋದು, ಮಿಲಿಂದ್ ಇರ್ಬೋದು, ದ್ಯಾಬೇರಿ ಮತ್ತು ಉಳಿದಂಥ ನಮ್ಮ ಸೀನಿಯರ್ ಆದಂಥ ಡಾಕ್ಟರ್ ಕೃಷ್ಣ ಪ್ರಸಾದ್ ಅವರು ಒಂದು ಯಾವುದಾದ್ರೂ ಒಂದು ಫಂಕ್ಷನಲ್ಲಿ ಮತ್ತು ಯಾವುದಾದ್ರೂ ಸೋಷಿಯಲ್ ಆ್ಯಕ್ಟಿವಿಟಿಯಲ್ಲಿ ನಮ್ಮ ಡಾಕ್ಟರ್ ಕೃಷ್ಣ ಪ್ರಸಾದ್ ಅವರು ಯಾವುದಾದ್ರೂ ಮುಂಚೂಣಿಯಲ್ಲೇ ಇರ್ತಿದ್ರು. ಅವರು ಕನ್ನಡ ಸಂಘದ ಸೆಕ್ರೆಟರಿಯಾಗಿ ಕೆಲಸ ಮಾಡಿದಾಗ ಅವ್ರು ಮುಂದಿರ್ತಿದ್ರು, ನಾವು ಹಿಂದಿಂದ ಗಲಾಟೆ ಮಾಡ್ತಿದ್ವಿ. ಆದರೆ ನಾವು ಗಲಾಟೆ ಮಾಡ್ತಿದ್ವಿ, ಅವರು ಹೋಗಿ ಮತ್ತೆ ರೂಮ್ನಲ್ಲಿ ಓದಿ ಫಸ್ಟ್ ರ್ಯಾಂಕ್ ನಾಟ್ ಓನ್ಲಿ ಇನ್ ದಿ ಫಸ್ಟ್ ಫೇಸ್ ಇನ್ ಹಿಸ್ಟ್ರಿ ಆಫ್ ಕರ್ನಾಟಕ ಯೂನಿವರ್ಸಿಟಿ ಧಾರವಾಡ ಫಸ್ಟ್ ಸೆಕೆಂಡ್ ಥರ್ಡ್ ಫೇಸ್ ನಲ್ಲಿ ಅವ್ರೇನು ಫಸ್ಟ್ ಸೆಕೆಂಡ್ ಥರ್ಡ್ ಬರಲಿಲ್ಲ, ಫಸ್ಟೇ ಬಂದು. ಈ ಗಾಟ್ ಫಸ್ಟ್ ರ್ಯಾಂಕ್ ಇನ್ ಆಲ್ ದಿ 3 phases. ಸೊ ಐ ಥಿಂಕ್ ಬಿಗ್ ರೌಂಡ್ ಆಫ್ ಅಪ್ಲಾಸ್ ಟು ಅವರ್ ಸೀನಿಯರ್ ಅಡ್ಮಿನಿಸ್ಟ್ರೇಷನ್ ಸರ್. ಸೊ ನಾನು ಭಾಳ ಹೆಚ್ಚು ಯಾಕಂದರೆ ಸರು ಮೋಸ್ಟ್ಲಿ ಇದ್ರ ಬಗ್ಗೆ ಹೆಚ್ಚಾಗಿ ಮಾತಾಡ್ತಾರೆ. ಈ ನಮ್ಮದು ಒಂದು ಇನ್ಸ್ಟಿಟ್ಯೂಟ್ ಬಗ್ಗೆ ಒಂದು ಸ್ವಲ್ಪ ಹೇಳ್ಬೇಕಂತ ನನಗೆ ಮನಸ್ಸು ಬರ್ತಾ ಇದೆ. ಯಾಕಂದರೆ ನಾವೆಲ್ಲ ನೋಡೋದ ಹಾಗೆ ನಮ್ಮ ಆಫ್ಥಾಲ್ಮಾಲಜಿ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಕಿಮ್ಸ್ ಹುಬ್ಳಿ ಸಾಕಷ್ಟು ಬದಲಾವಣೆಯನ್ನು ಕಂಡಿದೆ. ಮತ್ತು ಇನ್ನೂ ಹೆಚ್ಚಿನ ಒಂದು ಉತ್ತಮ ಅಥವಾ ಇದಕ್ಕೆ ಅಪ್ಗ್ರೇಡ್ ಮಾಡಲಿಕ್ಕೆ ತಮ್ಮಿಂದ ನಾನು ಸಲಹೆಯನ್ನು ಓಪನ್ ಆಗಿ ಕೇಳಲಿಕ್ಕೆ ಬಯಸುತ್ತೇನೆ. ಯಾಕಂದರೆ ತಾವೆಲ್ಲರೂ ನುರಿತ ಆಫ್ಥಾಲ್ಮಾಲಜಿಸ್ಟು ಸೀನಿಯರ್ಸ್ ಇದ್ದೀರಿ. ಅಪ್ಗ್ರೇಡಿಂಗ್ ದಿ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಆಫ್ ಆಫ್ಥಾಲ್ಮಾಲಜಿ ಇನ್ ಕಾರ್ನಿಯಾ ಆ್ಯಂಡ್ ರೆಟಿನಾ ಸ್ಪೆಷಾಲಿಟಿ. We have purchased high-end OCT machine, laser vitrectomy machine worth more than 1 crore. We are in the phase of developing specialty clinic, glaucoma, retina, cornea also. And regularly we are conducting camps, not only in Dharwad district, even Haveri, Bijapur district also. And we are planning to send our faculty for specialty training to regional institute. And we are in the process of procuring high-end microscope covering both anterior segment and posterior surgery, again more than 1 crore. ಇದಕ್ಕೆಲ್ಲ ನಾನು ಸ್ಪೆಷಲ್ ಥ್ಯಾಂಕ್ಸ್ ಹೇಳ್ಬೇಕಂದ್ರೆ ಡಾಕ್ಟರ್ ಆರ್ ವಿಶಾಲ್, ಹೂ ಈಸ್ ಆಲ್ಸೋ ಅಲ್ಯೂಮಿನಿ ಆಫ್ KMC. ಸೊ ಅವರು ರೆಗ್ಯುಲರ್ ಆಗಿ ಇಲ್ಲಿ ಮೀಟಿಂಗ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. KMC ಅಲ್ಯೂಮಿನಿ ಇರೋದ್ರಿಂದ ಪ್ರತಿ ಸಲ ಅವರು ಮತ್ತು ಪೇರೆಂಟ್ಸು ಇಲ್ಲೇ ಹುಬ್ಬಳ್ಳಿಯಲ್ಲಿ ಇರ್ತಾರೆ. ಬಂದಾಗ ಅವ್ರ ಮನೆಗೆ ಹೋಗಿಂತ ಮುಂಚೆ ಮೊದಲು KMC ಬಂದು ರಿವ್ಯೂ ಮೀಟಿಂಗ್ ತೊಗೊಂಡು ಹೋಗ್ತಾ ಇದ್ದಾರೆ. ಅದರಲ್ಲಿ ಆಫ್ಥಾಲ್ಮಾಲಜಿ ಡಿಪಾರ್ಟ್ಮೆಂಟಿಗೆ ಫಸ್ಟಿಗೆ ಅವರು ರಿವ್ಯೂ ಮಾಡೋದು. ಯಾಕೆ ಅವ್ರಿಗೆ ಅಷ್ಟು ಆಸಕ್ತಿ ಇದೆ ಅಂತ ಗೊತ್ತಿಲ್ಲ. ಮೋಸ್ಟ್ಲಿ ಅವರ ಪತ್ನಿ ಆಫ್ಥಾಲ್ಮಾಲಜಿ ಇರೋದ್ರಿಂದ ಅವ್ರಿಗೆ ಏನೇ ಇರಲಿ, ಬಟ್ ನಮ್ಮ ಸಂಸ್ಥೆಗೆ ಭಾಳ ಹೆಲ್ಪ್ ಆಗ್ತಾ ಇದೆ. ಸೊ ಮತ್ತು ನಾನು ಈ ಸಮಾರಂಭಕ್ಕೆ ಸತೀಶ್ ಶೆಟ್ಟು, ಮಿಲಿಂದ್ ಗಲಗಲಿ ಮತ್ತು ಕೃಷ್ಣ ಪ್ರಸಾದ್ ಅವರು ಕರೆದು ಇಲ್ಲೊಂದು 2 ಮಾತಾಡೋದಕ್ಕೆ ಅವಕಾಶ ಮಾಡಿಕೊಟ್ಟಿದ್ದಕ್ಕೆ ಮತ್ತೊಮ್ಮೆ ನಾನು ತಮಗೆ ಧನ್ಯವಾದ ತಿಳಿಸ್ತೇನೆ. ಆಮೇಲೆ ಈ ಒಂದು CME ಇನ್ನೂ ಎಲ್ಲರಿಗೂ ಹೆಚ್ಚಿನ ಒಂದು ಇದರಲ್ಲಿ ಸಕ್ಸಸ್ ಆಗಿ ಈ ನೀಡಿ ಪೇಷಂಟ್ಸ್ಗೆ ಭಾಳಷ್ಟು ನೀಡಿ ಪೇಷಂಟ್ಸ್ಗೆ ಉಪಯೋಗ ಆಗಲಿ ಅಂತ ಹಾರೈಸಿ ನನ್ನ 2 ಮಾತುಗಳು ಮುಗಿಸ್ತೇನೆ. ಜೈ ಹಿಂದ್, ಜೈ ಕರ್ನಾಟಕ.
ಈಗ ಈ ಕಾರ್ಯಕ್ರಮದ ಅಂತಿಮ ಘಟ್ಟ ರಾಷ್ಟ್ರಗೀತೆ.
अधिनायक जय हे भारत भाग्य विधाता.
Thank you all the delegates. Let's begin with the session. So, of the cataract surgery, everyone would want to distance intermediate and near vision.
To aid this, there is autofocus probe. To provide more information on this, I would like to call the next set of doctors. I request Dr. Shilpa Kolkini ma'am to please come on the stage.
A very good afternoon to you all. We go to the second session now, which is distance, intermediate, near for all, autofocus probe. I invite the chairperson, Dr. Ravindra T. Co-chairperson, Dr. Lakshman Dasar. And the moderator, Dr. Ravindra Karni. Please come up here. I now invite Dr. Satyamurthy sir to please introduce our speaker, Dr. R.C. Shah from Mumbai.
It gives me immense pleasure to introduce Dr. Ramesh Shah, born on 25th October 1957 in Mumbai. He had his initial education at Sahakari Vidya Mandir, Tharadevi, Mumbai. Went to Jai Hind College, did his inter-science from there. He did his MBBS from GS Medical College and then his DOMS and MS Ophthalmology. He's a gold medalist in MS Ophthalmology. Go to Dr. Ramesh.
Moderators. Moderators.
Hello dear friends and colleagues, we are very happy. Autofocus Pro looks like monofocal but works like multifocal. It is an aspheric polyfocal progressive lens.
On behalf of myself and Dr. Kakaria, I thank Dr. Satish Sheth and Karnataka and Hubli Ophthalmic Association to give us an opportunity to speak about multiple innovations. And this is one innovation which has worked extremely well. We have sold about 20,000 lenses in the first year, probably the largest multifocal lens selling last year. These first 3 months of this year also, we almost crossed 10,000. We are expecting 40,000 and next year we are expecting 1 lakh lenses. I present to you the unique varifocal, I would not say multifocal, I would say very focal, which has not got any rings and it follows the principle of Verilux lenses, glasses.
Autofocus Pro progressive lens of the Autofocus Pro looks like monofocal but Autofocus Pro looks like monofocal but works like multifocal. It is an aspheric polyfocal progressive lens without any diffractive rings. It is static and fixed in the bag. There is no mechanical pseudo accommodation, yet it functions like an autofocus lens, hence the name. Progressiveness of this IOL is clearly visible on 9-depth OPD scan, like varifocal progressive spectacle lenses. This is the schematic diagram of autofocus progressive polyfocal optic, which gives excellent DIN vision, distance, intermediate and near, by green technology, gradient refractive index. There is no loss of light energy because there are no diffractive rings, so there are no photons which are lost. This is the schematic optic, and as you can notice that even with different sizes of pupil, the ratio of the distribution of light remains the same. Zigzag serrated outer edges of L-shaped haptics, inspired from postal stamps borders, gives us rock-solid rotational stability. Large and horizontally oval optic covers full visual field, hence there is no negative dysphotopsia. And 6 mm long L-shaped zigzag-edged haptics provide rock-solid rotational stability. Let us see a short video of implantation of Autofocus Pro IOL. Optics Lifeline Autofocus Pro IOL. Please notice 2 dialing holes and zigzag outer edge of haptics. Zigzag outer edge of L-shaped haptic loops gives excellent rotational stability, easy loading and easy folding of optic and haptic. Smooth and easy implantation through 2.6 mm incision, easy insertion of leading loop into the bag, as well as that of the trailing loop into the bag. When we rotate the lens, we can actually feel the tactile resistance at the fornix. And we can also see the fornicial lens epithelial cells getting scraped out by the edge of the loop. You can see the debris coming out. Dial the lens in such a position that 2 dialing holes come in the upper half of the eyeball. No rotation during anterior visco removal. No rotation even while removing the retroial visco. Stable even while we nudge the IOL. Remain stable even when eyeball is nudged with 2 stick swabs gently or forcefully. No rotation, even with no hypotony, even with so much of force. It's a rock solid rotational stability of this IOL thanks to the Z. At any size of pupil, light distribution proportion remains same, hence it is pupil independent. Angle kappa or angle alpha are of no significance or importance. And as you can notice, there is no light energy loss because there is no destructive interference or diffraction. In retroillumination, we can barely perceive different zones of autofocus pro IOL. This is the only ringless polyfocal progressive IOL having all the 3 zones in central 1 mm. This is the typical post-op fogging over refraction versus distance visual acuity chart. And as we can see, from +1 to -3.5, the vision almost remains the same. This nearly flat DOF chart on the minus side is suggestive and indicative that autofocus pro IOL behaves like the natural crystalline lens of a teenager after implantation. There is no need for mono, micro mono or mix and match vision. Autofocus Pro is a forgiving IOL for the post-op refractive surprises from +1 to -1 diopters. You really don't need to be so acute, so vigilant and so apprehensive about IOL power calculation and formulae. Even without an optical biometer, results will be excellent. No subconscious anxiety or apprehension for eye surgeons on post-op day 1. Contrast sensitivity is as good as a young adolescent as measured on Pelly-Robson chart. Any patient with clear cornea and healthy macula is fit for this autofocus pro lens. With crisp and clear vision at all distances, without any negative or positive dysphotopsia, autofocus pro is also a presbyopia correcting IOL. All near vision intensive occasions become spectacle free and as easy and as clear as a teenager. There is no optical noise as it is in diffractive ringed IOLs. Hence, there is almost no neuroadaptation to multifocality in this lens. It is instantly accepted and adapted to. It can be implanted in monocular cataracts also. It can be implanted in previous eye having a monofocal IOL and also in previous eye having a ringed multifocal IOL. Out of more than 5,000 implanted, not a single patient complained of negative dysphotopsia. Autofocus Pro IOL is semi-oval with 7.5 mm horizontal and 6.3 mm vertical diameter. Conventional 6 mm optics IOL give rise to negative dysphotopsia due to this gap. Autofocus lens is large enough to cover
The 5,000 figure has crossed almost 20,000 now. And my personal figure for this lens is crossed about 6 to 7,000 in last 1.5 years. There are special conditions in which I have put this lens, out of which post-refractive surgery is the first number. I must have done about post-LASIK about 15 patients. Now all of us will face this problem. They have lived without glasses for so many years after LASIK. And when they get a cataract, they insist that they don't want to wear the glasses further. So this lens has been put in almost all the patients which have undergone at my place with LASIK surgery. I was doing a lot of RKs in the past. So those patients also have come, and about 12 patients of post-RK with proper calculation of the power, I have put this lens. The only thing in RK, the pupil size is more than 5 millimeters. I don't put this lens because the cornea is a dual refractive power. Center and the peripherals are different. And children, about 12 children we have put this lens, out of which 4 of them are bilateral, and their independence for near is almost significant. It's almost nearly 100%. Nobody is wearing the glasses, at least for reading. They might grow, the number might change, the refraction might change for distance. But what we are doing is we are making them independent of bifocal glasses. And the bifocal glasses, the children's performance in all activities, including the sports, is quite restricted. Because they cannot have this kind of quality of vision with bifocal. They might maintain, manage it. So this is one lens, even if the patient does not pay, we pay from our pocket, but we insist to put this lens in all the children cases. In the past, we were using hydrophilic lenses, but last 3-4 children, we have used hydrophobic lens because that is now available. So with this vast experience of mine, we have done about 18,000 multifocal in my life. This is probably the most successful lens. And I thank Dr. Ila Kakadia, who has initiated both of us to think about it. And by working with the other companies for so many years, it has helped us to design this ideal varifocal glass for all of us. In my practice, this specific design is about 90% of my cases, which I do almost 10 per day. And second thing is, I don't use any imported lenses. The whole idea of this to replace the monofocal with affordable varifocal glass. So I don't use any foreign lenses in my practice. In Mumbai, you can understand that how much demand of imported lenses are there. Unfortunately, we treat the patient's pocket, not the need of the patient. So I changed my strategy from the beginning only. And what is best in the interest of the patient, forget the cost wise. Even if I don't get the money so much, which I might get in imported lenses. But this was my dream from the beginning. We have designed this lens, I have thought of this lens 15 years back. And the company where I was working, they were not interested because they are not guided by the foreign surgeons. So they refused to accept it. And Dr. Gandhi, we are modifying these lenses to some extent to improve the quality of vision for reading and make it more pupil independent. The first vision was little less pupil independent. We might have to make a small sphincterotomy. But the new one, which is now there, where we have modified the zones, it is so difficult to modify the zone. The 0.9 millimeter in the center has got all the 3 powers. You can imagine the amount of precision that you need. So almost 95 to 98 of our patients, including Dr. Kakar, I think many of you are using it. They are extremely happy. 2 or 3% of the patients are not happy, and they are never going to be happy even otherwise also. So we don't bother about those 5%, but we are bothered about, I chase those 95%, not the 5%. And bilaterally this lens works wonder. Even the threading of needle is wonderful. Regarding the depth of focus in your daily life, suppose you want to find out how best they perform. I ask the patient to stand on the staircase, about 11 staircases are there, on the top of the floor, and request the patient whether they can see clearly all the steps with same sharpness. And almost 100% say yes, they can see with the same sharpness. If you want to increase this further, the depth to evaluate, you can ask them to stand on a platform, the bridge of the railways, where they have almost 42 steps, and ask them to stand on top. They can see all the things, all the steps so clearly, which suggests that which is equivalent to a child vision. The other thing, which somebody is the housewife, we ask the patient that they are working on a platform, whether they can see all the things which are kept on platform right near as well as distance, whether the clarity is same or not. And they almost all of them have agreed. So when you tell all these things to them, they never refuse to put them in. In fact, I get so many patients which other surgeons have refused because they are not putting this level. And they have come to me. I do almost 3 patients rejected by others per week in my practice. If any questions are there, we can answer.
Yeah, we can take the questions after lunch. We are running short of time. And I request Dr. Kakadia sir to come over to the podium now. So there is a little story behind how this autofocus Pro was developed, how the idea was conceived. So idea, once they are put into practice, that becomes a reality. Sir, please.
It took almost 2 to 3 years to design. First one was failed. Then we have misunderstanding between us and Dr. Vikrant. So instead of thinking about the diameter, he thought of radius. And the whole batch was wasted, almost 2,000 lenses we have taken back. And the money was lost. So this is the way the evaluation has taken place. And we are very happy that now almost we are certain of this lens. And probably next 3 to 4 months, we will have a toric lenses. The other thing which I have designed and doing it, that I don't do any toric lenses. When the K reading is less than 2 diopters, I do my AK, which I was doing in the past. And that has given wonderful results without doing the toric lens with this autofocus Pro. In almost 90% of the cases, I do toric lens only if it is more than plus 2.5 diopters.
So the interesting thing so happened, I would like to introduce 2 persons. Dr. Ila, is she there in the audience? I think she has gone to the room for packing the bags. My better half, Dr. Ila, she became presbyopic. She didn't want to use the near vision glasses. So she said to me, what is the alternative? So I said, you start using multifocal contact lenses. Now those of you who would dispense Bausch+Lomb multifocal contact lenses to your patients, we know that it looks plano, there are no rings, there is nothing, and yet it works perfectly well for distance, intermediate and near, without any glare, without any halos. So she said me that if a contact lens can be made like this, why can't a multifocal lens be made like this? And then she was after me and RC that you better talk to Bausch+Lomb guys. So we went to Bausch+Lomb's R&D head at one of the ASARS conferences. And we said that you already have an Anista platform, which is an excellent material, which is totally glistening free. Why can't you copy the Bausch+Lomb multifocal contact lens design onto the IOL? So they said that in case of contact lens, there is air in front and there is aqueous behind, or a cornea behind. So the refractive index is 1 in front and 1.236 behind. So to achieve that kind of optic is possible in contact lens. But in case of IOL, there is aqueous in front and vitreous behind. And the refractive index difference between the aqueous and the vitreous is very, very minimal. It's almost negligible. So it is not possible. वो ऐसा करके हमको भगा दिया. But then Ila was after me that you have to find a material which will behave like a contact lens even inside the aqueous, having this minimal refractive index. So we started searching for the material, and here is Dr. Vikrant Bale. We can come here. Dr. Vikrant Bale is a unique person. He owns the Lifeline Medical Devices company, which manufactures intraocular lenses. Not only for our design, but he manufactures for 42 different countries. And he is a unique person that he is an MBBS doctor. He started residency in ophthalmology, then switched his mind and he went to study polymer chemistry and plastic engineering. And then he became an engineer, and his father, Dr. Vinod Bale, he is a polymer chemistry PhD, and he was the one who first synthesized the hydrophobic acrylic material at IOCare way back in 1995. So he had that knowledge and inheritance and his zeal and zest. So he, from MBBS doctor and first year resident in ophthalmology, became an engineer and then started a company. Today, his company manufactures intraocular lenses for 42 different nations' governments. It is approved by Brazil, Argentina, most of the former Soviet bloc countries, most of the Asian countries, and almost all the African countries, and WHO. More interestingly, he is now an expert of setting up an IOL company. So he has already established more than 18 intraocular lenses companies around the world, in Egypt, in Vietnam, in China, in various other nations, where 20-30 doctors would form a group. Each one will invest 10, 20, 30 lakhs of rupees and then borrow the remaining fund and create a company. So he provides the technical guidance from acquiring the land to the IOL is ready, FDA approvals are done. He is a consultant now for the intraocular lenses, and we learned so much from him in these last 5-6 years. So idea of Eli's force was asking and creation of that idea. So if we were the architects, he was the civil engineer who actually materialized the lens. And the company is top of the line. It's state-of-the-art facility, and it is worth visiting. So on behalf of Vikrant, I invite you all to come once to Aurangabad, be the guest of Vikrant, and visit the company and learn the entire process of IOL button manufacturing till the finished intraocular lens goes into the market. That's an experience it's worth taking, and you all are welcome on a Saturday, stay overnight, see the entire process on a Sunday, and then come back. And if you come a day before, then he can take us to Ajanta Ellora, Daulatabad Fort, and various places around Aurangabad. Right. So thank you so much for a patient listening. And Vikrant is also. He's very shy, so I spoke on his behalf, but now he's going to speak a little.
Good afternoon all. I thank you Karnataka Ophthalmology Association as well as Hubli Dharwad Association for giving us the opportunity to be a part of this wonderful event. I mean, expecting so many delegates for a CME for a single day, it's an achievement for us as well, and special efforts taken by Hubli Dharwad Association and Satish Seth sir. So I thank you all of them and the team of their PGs there. They are working, I guess, day in, day out. And I thank you all for being a part of this event. Thank you so much. Thank you.
This is one slide which I would like to show you specifically. If you see down, the power distribution is if you see this, this is how the lens has been evaluated. This is a unique combination of doctors involving in designing, evaluation, everything in human eye. And this is one thing which is there in OPD scan, where you see these powers. This is exactly similar to what the varifocal glasses are there. This is in situ with OPD scan. And if you move the cursor here, they will tell you how much is the addition here, how much is the addition here, how much is the addition here. So every lens in my place is evaluated with this, as well as the depth of focus is done for everybody. So we could detect some 6 or 7 lenses we turned out to be slightly defective. And we realized that where was the mistake. So every day there is a continuous improvement in the quality. That is why we have more or less consistency of using these lenses. This is one thing which is a wonderful thing which is there in OPD scan. And we evaluate every lens on the OPD scan. The smaller pupil as well as the larger pupil. This is a small pupil. The other one we use a larger pupil. We get the power. See, here is the addition of power, which is, and this is done without the cornea. There is a provision in which you can remove the cornea totally and see internal alone. So even if there is a keratoconus, we can detect this thing by minusing the cornea. That is a unique feature of OPD scan. A constant is 117.5 for hydrophilic and 118.8 for hydrophobic. Optical always.
Do you need to check for spherical aberrations?
Spherical aberrations of the cornea, yes, but most of the time in 4 or 5 millimeters you don't get so much. You don't get so much. There are incidences where
Because all 3 zones are in the pupil.
All 3 zones are.
Yeah.
There are about 10 to 12 patients I do per year. LASIK, if there is a power which changes, especially if you have a 0.5 or 0.75 cylinder, no? They are very unhappy. Or if it is plus 0.5 minus 0.75 cylinder, they are extremely unhappy patients. Their quality of vision is very poor. In all these patients, there are 2 incidences in which the cylinder was wrongly calculated and the cylinder came out to be minus 3 cylinders. So all these patients we have done LASIK, but it is based on spherical aberrations. So we adjust the spherical aberration in such a way that they go around 0 or about minus plus 1 or minus 1 on either side. In those patients, the quality has improved significantly. And when you do a spherical aberration base now, the rest of the spherical aberration is taken care of. So you need not go to each one of them if it is done with a spherical aberration, because it is calculating overall all 360 degrees. And NIDEC is a wonderful machine to have these various combinations. You have a 220 combinations available in this NIDEC machine.
Great. Thank you so much, Dr. Asisha. That was a wonderful, really innovative lens that we all look forward to putting. Now we have Dr. Arvind Moria. I think there's a video which is going to be played. He's from NAIMS, Hyderabad. The use of Autofocus Pro IOL in institutional practice.
Yeah, Dr. Arvind Moria was supposed to be with us here today. So just 3 days ago, this program is actually overlapping with Russian Ophthalmic Conference at St. Petersburg. So on the invite by Dr. Boris Malyugin, so he is going to deliver a lecture on Autofocus Pro in St. Petersburg in Russia. So we are going to have him online during the panel discussion. So he sent the video with a voiceover for us for this presentation here. And yeah. So he was not sure that he would get a Russian visa. So he was very sure that he wanted to be with us here today. But then he applied for e-visa and he got it. So he had to leave.
Premium IOL within reach, free free of negative dysphotopsia and no glare halos with good depth of focus. Today, the cataract surgery is fast becoming a refractive surgery as patients want a crisp and clear distance, intermediate and near vision. So, what is an ideal premium PCIOL? A no-negative dysphotopsia allows glare, excellent distance, intermediate, near vision and also cost-effective. Well, the answer is Autofocus Pro, a make in India and world's best designed IOL, which is a ringless and polyfocal progressive. Autofocus Pro looks like monofocal but works like multifocal. It is an aspheric polyfocal progressive lens without any diffractive rings. This IOL is static and fixed in the back and there is no mechanical pseudo accommodation. Yet, it functions like an autofocus lens, hence the name. Progressiveness of this IOL is clearly visible on NIDAC OPD scan like varifocal spectacle lenses. Designs and dimensions are as follows. This is a schematic diagram of autofocus progressive polyfocal optic which gives excellent DIR vision, that is distance, intermediate and near vision by GRIN technology, that is gradient refractive index. There is no loss of light energy because there are no diffractive rings, so there are no photons which are lost. This is the schematic optic, and as you can notice that even with different sizes of the pupil, the ratio of distribution of light remains the same. These two dialing holes are also position indicators to be kept in upper half of the eye. They also help to drain out any remaining retro-IOL viscoelastic. Zigzag serrated outer edges of L-shaped haptics inspired from postal stamp borders gives a rock-solid rotational stability. Large and horizontally oval optic covers full visual field, hence there is no negative dysphotopsia, and 6 mm long zigzag haptics provide rock-solid rotational stability. This PCIOL is made from glistening-free acrylic copolymer in which 74% is hydrophobicity and 26% is hydrophilicity. Let's see few surgical videos of implantation of this IOL. As you can notice, there are two dialing holes and zigzag outer edge of the haptics. Zigzag outer edge of L-shaped haptic loops gives excellent rotational stability. Its optic and haptics loading and folding is very easy. It requires implantation through a 2.6 mm incision, which is quite easy and smooth. The insertion of leading haptic loop in the capsular bag as well as the trailing loop in the bag is easy. Then we rotate the lens. Then we can actually feel the tactile resistance at the fornix, and we can also see the cornicial lens epithelial cells getting scrapped out by the edge of the loop. We can see the debris coming out, which decreases the chances of PCO. The lens needs to be dialed in such a position that the two dialing holes come in the upper half of the eyeball, which is followed by hydro at the incision site. There is no rotation of the lens while viscoelastic removal anteriorly, as well as while removing retro-IOL viscoelastic removal by the bimanual irrigation aspiration phaco cannula that remains stable when the IOL is nudged. At any size of pupil, light distribution proportion remains same, therefore it is pupil independent. Because of this, angle kappa or angle alpha are of no significance or importance, and it is clearly evident that there is no energy loss because there is no destructive interference or diffraction. In retroillumination mode, we can fairly perceive the different zones of the Autofocus Pro IOL. This is the only ringless polyfocal progressive IOL having all the three zones in the central 1 mm of the optic. This is the typical post-op fogging over refraction versus distance visual acuity chart, and it is evident that from one diopter diopter to -3.5, the vision almost remains the same. This nearly flat depth of focus chart on the minus side is suggestive and indicative that autofocus Pro IOL behaves like a natural crystalline lens of a teenager after implantation. With this IOL, contrast sensitivity is as good as young adolescent. All the patients with clear cornea and healthy macula are fit for this IOL. Autofocus Pro IOL has a great modulation transfer factor of 70% as monofocal. Like a bullet train after binocular implantation, the average reading speed was more than 200 words per minute without any problem. With crisp and clear vision at all distances, without any negative or positive dysphotopsia, Autofocus Pro is also a presbyopia correcting IOL. Most of the near vision intensive occasions become spectacle free and able to read as clear and crisp as a teenager. There is no optical noise as seen in diffractive ringed IOL, and there is almost no neuroadaptation to multifocality in this lens. In case of a monofocal IOL, only far vision is clear, whereas in case of Autofocus Pro IOL, the vision is simultaneously clear for near, intermediate and distant. Autofocus Pro IOL is the best choice for children as they need only monofocal spectacles for their myopia.
Thank you so much. Now we will move over to introduction of Dr. Sanjay Russell by Dr. Divices Pvt Ltd.
Car number 2529, kindly please remove the car. It's blocking the other car.
Pleasure and privilege. It is a pleasure and privilege to introduce Dr. Sanjay Russell, whose posts I very avidly have been reading on various very interactive WhatsApp groups that deal with cataract surgery. So Dr. Sanjay Russell has done his MBBS in 94 and MS Ophthalm in 97 from Government Medical College, Mirrors. During his residency, he mastered all techniques of SICS and has done a wide range of ophthalmic surgeries in his residency. He was selected on the panel of SICS Moscow 1995 as Solapur, even as a resident. He did his fellowship at Karanji. Along with topical phacosurgery, he does comprehensive ophthalmic practice of laser and lens-based refractive surgeries. Also, again, the spectrum is very wide. Sir does glaucoma surgery, pediatric ophthalmology, surgeries, medical retina, dactyology and oculoplasty, management of eye injuries, neuro-ophthalmology, and also, has facilities of eye banking, including the entire range of corneal transplant surgeries. He has had multiple scientific presentations at state levels, national and regional conferences. He has single-handedly conducted topical phaco workshop with live surgeries at Karanji at the start of this decade. He has specialized training in the technique of excimer laser LASIK surgeries and does a lot of charitable work and camps, including out of India. He's a life member of several important societies, including the AIOS, IMA, and the IRSI. And over to you, sir.
Thank you. Instead of good morning, I have to say good afternoon. And I would like to say this hall because it's already 2:30 and how many of you are really eager to listen to Autofocus Pro after two stalwarts and innovators who invented this IOL and start using their motivational speech was so Lifeline Medical Devices Pvt Ltd, Dr. Vikrant, and whole team of Lifeline for having me here and giving me the opportunity to throw a light on how to upscale private practice using Autofocus Pro. Now, while preparing a talk or slides, I had a question. What I can say after us innovator? You have saw two videos, two nice presentation, and mine is the third, to motivate you again and ask you to use this Autofocus Pro. But I will try my best level to convince you or motivate you to use this Autofocus Pro. This is a fantastic lens, and I thought why not to expand the horizon of this subject and split this topic into two. Upscaling of the private practice itself is a separate topic, and how Autofocus Pro helps to scale up the practice. So as far as scaling up the practice is concerned, we need to plan various aspects of our private practice strategically. There are various aspects of private practice to scale up or to go to next level, and then properly execute them properly to build our rapport or status in the society. And these aspects are establishment of aesthetically designed hospital building, ultra-modern and state-of-art infrastructure and premises which will not only add glory to your practice but uplift it and your status also. Yesterday I had an opportunity to visit ICRI, the state-of-art hospital built by none other than the most famous person not only in this area but in the ophthalmic society and ophthalmic family, Padma Shri, respected Padma Shri Dr. M.M. Joshi. He along with Dr. Guru Prasad, Dr. Satyamurthy, Dr. K.P. Krishna Prasad, his son Dr. Srinivas, Dr. Dipti, and list of ophthalmologists is endless. There are several ophthalmologists working behind this fantastic institute. They have set an example for all of us. How to scale up your practice, how to go to the next level. There are several faces here, big stalwarts I see in the crowd, like Jagdeep Kakdiya sir, Ashish sir, Ravi, Anaga. So many people, they have set their practice at a very high level. So we need to get inspiration from all those. So the next is having latest modern diagnostic and therapeutic equipments that will help us to offer various subspecialty services under one roof to cater and serve each and every single patient that comes to our hospital. Rather than referring, we should try to treat at a best possible way in our setup that will help to scale up our practice and go to the next level. Marketing of private practice in a various way itself is a big topic. I am not going in details of it, but all these people, the names we have mentioned, they know and they have used these strategies to uplift their practice. And the last point is adding newer and newer IOLs in our portfolio, IOL portfolio, and using them for giving better and better vision to our patients will definitely scale up the practice and lift your private practice. So coming to this fantastic IOL, I would like to take you back 3-4 decades. As all of us know that IOL has evolved in a very drastic and significant manner in this 3-4 decades, and every IOL help us to serve to the patient, give best possible vision, starting from 3-piece IOL to single-piece IOL, PMMA IOL to hydrophilic, hydrophobic, monofocal toric IOLs, to the era of press by multifocal IOLs, bifocal, trifocal, but every IOL had their own problems. So researchers and the people like R.C. Shah or IOL manufacturers, they crave for better and better IOLs. And then came the era of IOLs. Not every IOL is perfect. So in the quest to search for the perfection and giving best possible vision for all the distances, this progressive optic IOL came in the market, and We will discuss this IOL in respect to its design, its optical properties, light distribution, advantage over other IOLs, and precautions to be taken during implantation, and most importantly, its results and how this IOL helps patients to get a best possible vision for all distances. All these points are already covered in 2 talks. I am not going to repeat those, but few points I would like to highlight here, because the word forgiving IOL is mentioned in the video, previous 2 videos, and I say this is a forgiving IOL design because it's large 7.5 horizontal optic. Gives excellent IOL tolerance in cases of oval CCC. IOL tilt and decentration is not there, even your CCC is slightly decentered or oval. So this is a really forgiving IOL design, and of course the negative dysphotopsia, no glare, no halos is an additional benefit. Then large L optic zigzag, already the point is highlighted and stressfully said, I will not repeat. It has got a central posterior 360-degree apple square edge, as well as its peripheral portion has a square edge design. So it has got a double square edge design which prevents epithelial cell migration, dense epithelial cell migration, and definitely helps to reduce the incidence and chances of PCO. Its design and optical properties consist mainly the central optic, and it is divided into primarily three zones. The upper one is 60% for the distant, middle 15% is intermediate, and lower is a varifocal, which gives good near vision for all distances, as RC sir has already stressfully said that the patient gets very good depth of vision because of the near varifocal segment in the lower 25% of the IOL optic. The light distribution in this optic design, unique refractive optic design, is uniform throughout all zones. So the patient gets very clear, crisp, nice vision because of this light energy distribution across the all zones. If you see the slides here, the first one shows the principle of refractive diffractive IOLs, ringed IOLs, where you get a lot of diffraction and rings around light, halos. So this varifocal lens definitely gives crisp points in each zone, giving comfort to the night driving and freedom from halos and colored problems, even aberrations. The another point is defocus curve. It has got a uniform defocus curve. Again, I say this is a forgiving IOL because it gives peace of mind not only to the surgeon but to the patient as well. Even if you if you get a refractive surprise of say -1 diopter on either side, and while operating on premium patients, we are little apprehensive, or we get at the back of mind, we get little conscious. And this IOL gives you peace of mind because there are small errors while doing keratometry, doing biometry. In spite of we have best of the optical biometers or immersion techniques, we cannot guarantee every time next day patient will get a plano. Even IOL power formulas are not perfect. So this IOL gives peace of mind because it has got a uniform defocus curve in all zones. So these are a few examples. I have prepared this defocus curves for these patients, and you see here in all zones the defocus curve is pretty uniform. So this helps to give a best possible vision to the patient. Now coming to the precautions during implantation of the autofocus. You saw the videos, 2 videos, but I would say it is better to mark the cornea, whatever the marking system you use, mark exactly at 180 degree, 0 and 180 degree, and try to align that IOL at a 180 degree, because to get a vertical progressive effect of this IOL, we need to align this IOL horizontally, and it should remain there, and to this large optic haptic with the zigzag design definitely gives rock solid rotational stability. So let us see the video. This IOL can be implanted through any standard cartridge and injector. Any, like standard, those are front loading cartridges. This can be loaded onto the cartridge like any standard hydrophilic or hydrophobic IOL. This can be hydro-implanted, though it is not recommended by the company people or the innovators. You can use either visco or saline to load onto the cartridge. I am hydro-implanting with wound-assisted delivery. And this IOL has an excellent memory. You can see how it unfolds and how smoothly it goes. There are no scratches on the IOL optic. Now you can go below the IOL to wash the visco if you are comfortable or used to go below the IOL. Otherwise, IOL has 2 holes that will take care of the visco behind the IOL. Try to rotate so that zigzag design of the optic will scrub the fornices of the bag and try to remove the epithelial cells from the fornices. This is my standard practice for last 25 years. And make sure while closing you align the IOL exactly on your mouth. Now final and most important slide is coming to the results. I say sorry because I could not align these videos horizontally. I will minimize my presentation.
It will be horizontal.
And actually, this is one of the patients. Please listen to him. This is a patient. This is in Marathi. He is a bank employee and he needs crisp vision for all distances. This video is prepared first day post.
लाईटचं भौतिक चक्र दिसतं कॉन्ट्रास्ट कलर्स कॉन्ट्रास्ट सगळं व्यवस्थित दिसतं वाचताना पण नाही
Another very important point mentioned is the speed of reading.
अंगठा ठेवलाय ना तिथून
Just one speed of reading.
धर्म एकच आहे तो म्हणजे
N10
समाजाची सोय धरणात करण्याचे अजून सामर्थ्य फक्त एकाच
N8
पोटाला कोंडा म्हणून जर एखादा माणूस असेल
N6
आपल्या दुःखाला कारण देव किंवा दैवत नसून आपण असतो आणि कोणीही नाही.
So the speed of reading definitely
देव असताना तुला अडचण नको
नाही दिसते
स्वच्छ दिसतं ओके थँक्यू
The speed of reading is a very important criteria to determine the success of the IOL. Another criteria Dr. R.C. Shah said he clearly visible staircase at all distances. Another important criteria is doing all household activities for the housewife. They need to see everything clearly. So you can think of this IOL to each and every patient. The youngest patient I operated on is 12 years. He had a sharp pencil injury from limbus to iris and touched the center of the lens. Fortunately, I could convert that lens rupture into CCC and implant this IOL because I was thinking which IOL to put in such a young age to get that spectacle-free vision, good vision. Otherwise, that patient may go in amblyopia or say reduced to contrast. Even a ringed IOL give a ring glare and rings around the contrast sensitivity is not that good. So I thought, why not to go with the autofocus probe? And that patient is very happy. He is enjoying very good vision. In spite of perforation, fortunately we could save his eye from the infections, but he is enjoying 6/6 and N6 vision in that eye. So this type of technology helps certainly step up our private practice. And I humbly say, I am using this lens from its inception. When Pro version was not available, I am using this. And incidentally, I am the first person to try Omni Glow. You have seen so many innovations from morning. all those innovations, their primary focus is work for yourself and don't work for companies. Probably our frequency of thinking frequencies are matching each other. So that is the reason I am the first person when the OmniGlow was in the infantile stage. I took a demo. Dr. Jagdeep sir will agree to that. And Omni is a fantastic device which will help you to convert your ordinary microscope to the premium microscope. Why to give 50-60 lakh to the company for mere doing entry segment work? Do we really need that high-end microscope for doing entry segment surgery? We need to introspect ourselves. Where to spend our hard-earned money? That need to be given a second thought. And I second the thought of Dr. R.C. Shah sir. I am practicing for more than 25 years. I am not fond of all imported IOLs. I always push the Indian IOLs and I help our country grow rather than all our money go outside. Our Indian peoples are great innovators. Why not to follow them? Why not to put our ideas to do best and good vision to our patients rather than spending on multinational companies? Thank you.
Any more questions to Dr. Rizal or Dr. R.C. Shah? Because R.C. Shah cannot be found at any time later in life. I don't know. Because he is so busy in his practice, and that's how we missed him last time during our COSCON. Because he could not spare 3 days of time to come down to Hubli and do a live surgery. So whatever questions you have got on Autofocus Pro, you can clear it now or at the lunch. So if there are no questions, only then we break for lunch.
That means everyone is convinced. They will start using Autofocus Pro.
Yeah, that is the last talk, the last talk made all the difference. Sir, you want to say something?
One more point which I want to tell you, there is a small rotation of this lens. Usually nothing happens, even the quality of vision, everything is okay, but only the depth of focus slightly deteriorates. There are 2 patients which I had a rent in the PC, so I put the lens vertically and I could not rotate because of the fear that it might go inside. The patient is doing quite well, but his depth of focus is slightly down.
One point I would like to say. The point of here, the IOL rotation. One need to observe even post-op period, early post-op period, like say 1 week, 2 weeks, or in a month. If you see any rotation, there is no chance because you have the haptic is big enough. It has got a zigzag borders, so hardly any chance of rotation. But unless the fibroblasts they proliferate and you get a fibrosis in the capsular bag and the bag haptic adhesions are there, there are chances, maybe, very rare. One of my patient got say 25 degree of rotation. From 180 degree in the left eye, it rotated to 155 degree, and the patient had really problems with his clarity and vision. And other eye was absolutely good, 180 degree and good vision. So that patient could compare the vision. Always asking, and this eye is good, but this is not up to the mark. So repeatedly she used to come, and I was thinking what to do, because she came for follow-up after 3-4 months when the IOL was fixed in the bag. What I am trying to say here, I could not separate that haptic from the bag. The haptic design is designed in such a way that the fibrosis of the haptic and bag adheres to each other so firmly that you cannot move afterwards. So that is a very good point. If you align the IOL perfectly into 180 degree, if at all you have some decentration, center it immediately in the first month. Afterward, it becomes very difficult to rotate that IOL because of this design, haptic design, zigzag design. You get a firm adhesions and difficult to separate. I have done a lot of IOL exchanges, multifocal IOL exchanges, but this took really on me. What I did, I tore that adhesions. I brought that haptic out. I sutured through the limbus and then aligned on the 180 degree forcefully with the help of force of the suture. So that's rock solid stability this haptic gives. That is a very strong point of this iron.
Thank you very much.
One thing I would like to share, it was a mistake, not a mistake, I will say it was a blunder made by me. I've been using these lenses a lot. I got a library at my place, and since I got two tables, right and left, and when I got same patient both right, to save the time, my table is rotated, and then I got, in the hurry, I got this down like this to read. Then I realized, and then I had to take him immediately, and it was a bit difficult to, but using a lot of disco in the bag, I could rotate it. So that was a blunder what I had done, but it has been very good.
It was 180 degree opposite?
Yes.
So, last week I had a case, so the rexis got tore off at one point. So I implanted the IOL, as Dr. Asar was mentioning about 30 degrees rotation, that you see after 1 week sometimes. On the table, if it is already 30 degrees, and this is such a rigid IOL, it just goes and sits with, its haptics at both the furnaces. It just doesn't move. It just doesn't move. So patients, relatives were very anxious. First eye का surgery 15 मिनट में हो गया. दूसरा eye का surgery 45 मिनट से patient बाहर नहीं आ रहा. They were only worried कि कुछ complication हो गया, something has happened. I was making sure that there is no complication, but this IOL was not ready to rotate. Whatever I tried, it didn't rotate. Finally, it stayed at 30 degrees, and I said, let me see. Follow-up this thing. So on follow-up when she came, it was still at 30 degrees only. It didn't move. It didn't move. It was like a rock, and she was again 6, 6, and 6. So I just convinced the relative. He was a police constable. So I told him that she has some problem in her second eye. No, that's the reason lens was not moving. So I never said that we had a rexis runoff and all. But patient is happy.
Thank you very much.
All is well that ends well.
Yeah.
I think now everyone is auto-focusing on lunch. So that's break for lunch. Thank you so much, everyone.
Thank you, ma'am, sir.
Now I request Dr. Shilpa Kutpani ma'am to hand over token of appreciation to Dr. Lakshman Dasar sir.
Sir, side line.
And Dr. Ravi Kulkarni sir.
I request Dr. Suresh Isur sir to kindly present the memento to Dr. Shilpa Kutpani ma'am. I request Dr. Umesh Hiremat sir to kindly present the memento to Dr. Shilpa Kutpani ma'am.
Thank you sir. Thank you ma'am. Now let us break for lunch break for only of 20 minutes. Kindly join us in afternoon for interesting.
awarded 18 prizes. High repute.
To Hubli Dharwad Ophthalmic Society and Karnataka Ophthalmic Society. In fact, I am a KOS member and I am proud to be one. And thank you Dr. Satish also for inviting me here, and thanks to Lifeline Medical Sciences. After listening to the lovely, expert, innovative, creative talks that we saw in the morning, and this is specifically for the women in our ophthalmic society, and today I think more and more women are being a major part of the ophthalmic society. So this is dedicated to all the women here, breaking the glass ceiling. So if you ask us what is entrepreneurship, yes, by definition it is how you increase your business and risk-taking abilities, but I would put it as it is living a few years of your life like most people won't, so that you can spend the rest of your life like most people can't. So this is basically from a French word called as entreprendre, which means to embark upon or to start. And why an entrepreneur? All of us are doing clinical work, all of us are in our own practices, but being an entrepreneur helps us to unlock our own personal potential. It fosters social and economic development not only of your own practice, but also of all your employees, and it creates job opportunities. And in my case, and in the case of all those who are giving more jobs to women, it helps in women empowerment. So let us see some 10 steps that I had in mind and how I went through this journey. So the very first step that you need to do is define your goals. Whether it is your personal goal or a professional goal, you need to think for yourself where you would like to be 1 year, 3 years, 5 years from now. It has to start from your mind. Now, whether it is growing your family, like having kids, or whether it is having growth in your revenue, whether it's expanding your own present center or having multiple centers, increasing your academic presentations, or going into research, having more papers, publications, or getting into leadership roles at state, national, or international levels. Remember, only you can change your life, only you can change your destiny. So you have to think for yourself and be sure. So if you are thinking that yes, I want to be an entrepreneur, you have to be very sure that yes, this is what I want to do. And what does it take to be an entrepreneur? So these are the characteristics. So first and foremost, you need to be highly motivated to do this. You need to be passionate. So there are these 4 P's: passionate, perseverance, persuasiveness, and perseverance. You need to have that vision that yes, 5 years from now I need to have 4 centers, or 5 years from now I will need to reach a target of so and so revenue. You need to be confident, and confidence in decision making of yourself. Of course, you should take the advice of those people around you or whom you think fit to advise you. You need to have that risk-taking ability. Not everything is going to work out the way you want to. You need to have a persistence towards your goal, and also a leadership quality to lead your herd along with you. In fact, this article in the print in May 2020 said that female type leadership is actually the need of the hour because it involves resilience, courage, flexibility and empathy, which is very feminine. But friends, it's hard to be a woman. You must think like a man, act like a lady, look like a young girl, but work like a horse. Am I right? So this debate between men versus women is always going to be there, even though today we are inching towards a gender-neutral environment. This debate is never going to cease. In fact, the World Economic Forum said that it's going to take 100 years for this gender disparity to go. So we are not going to see it. If you look at Indian AIOS members, there are almost equal men and women if you see this. But how many single women entrepreneurs in private practice, working independently in private practice, do we actually see in India? So yes, probably it's a man's world. India has always been a patriarchal society and the female is always considered to be the weak one, the abla nari, who is always dependent on the man in the family. So whether it is the father in the first 25 years or the husband or the son in the last innings of her life. But friends, yes, taking blessings of Goddess Durga, we are, I think, quite capable of managing both the home front as well as our professional lives. In fact, there is no force more powerful than a woman who is determined to rise. All it needs is to have the right mindset. And with the right mindset, we can't lose. We either practice what we have learned or we learn what we need to practice. कहते हैं, अगर किसी चीज को दिल से चाहो, तो पूरी कायनात उसे तुमसे मिलाने की कोशिश में लग जाती है. So after you have defined your goals, the second step is strengthen yourself. Physically, mentally, financially, and most importantly, spiritually. Because you need to go through tough times. You have to be ready to go through tough times. And then start work in that direction. No matter what your ability is, you may be very learned, you may be very skilled, but it's effort that is going to ignite that ability and turn it into accomplishment. You have to be ready to work very, very, very hard. You have to eat, breathe, drink your goals. You have to be extremely passionate about what you're going to do. Most importantly, you have to upscale your own skill sets. There is no place for mediocrity. You have to be extremely good in whatever you're going to do. Yes, first and foremost, your clinical skills, surgical skills, diagnostic skills, and all the equipment that will be required to achieve those skill sets. You have to be ready to invest in them. And you have to be also interested and passionate about the management process. Today, more and more practices are being sold to corporates, and the most important reason being they don't want to go through the hassle of administration and management of their own practices. A lot of young people are also giving up their own practice because they don't want to get into this. But we have, if you want to be an entrepreneur, then you should be happily doing it. Yes, you can build your own team to do it. It's not that you have to be everywhere, but you have to be learning to plan, to organize, to direct, to coordinate, and to control things at every level. Finance is something which we as women always neglect, and we always leave it to our better halves. But it's very, very important for all of us as women to be financially literate, financially dependent, and to know the finances of your company or your business. What exactly do I mean by financial literacy is basically you need to have the skills enough to understand your own financial management, budgeting, and the investing, whatever is needed. Definitely you will have financial advisors. You can take the help of your husband, family, whoever it is, your CA, but you should talk to your CA directly, talk to your bankers directly, and see to it that you get the best deals, negotiate with vendors directly, so that you develop that rapport with each one of these vendors, so that they directly talk to you. So this has to be done. Are women feeling financially empowered? And it is very sad to see that even in 2019, there was a whopping 68% women who felt that they were financially less secure. So being financially literate and independent is extremely important. In fact, it is said that India even after having 50% of the population being women, we still contribute to less than 20% of the GDP. And it is said that 770 of refine your goal alone. You have to work together with a team and learn to delegate. So you have to manage human resources, which means how to staff, how to recruit your perfect employee. You have to build their skill sets, you have to train them, and you have to keep monitoring their performance. So you have to be a true leader and develop leaders in the hierarchy in your organization. You cannot be a single leader, it cannot be a flat organization. There has to be a hierarchy. So HRM is one of the most challenging and the most important part of your organization. Remember, when you develop SOPs, so how will you develop and build more centers? For that, you need to have your SOPs or the standard operating protocols that we say in place. Once you have that, it can be easily replicated in other centers, and you can have people like a CEO or the HR person or an operations manager or an administrator who would look at each of these SOPs, whether they are being followed or not, continuous training of your manpower, and appraisals and reviews very frequently. Time management is something which I don't think we can more emphasize. Remember the Eisenhower decision matrix. If there's something important and something urgent, both, do it and do it now. If there's something important, but it's not urgent, you can delegate it because you don't need to waste your time on it. If it's something important but not urgent, you need to decide when to do it, but you have to schedule a perfect time to do it. I use a to-do list on my mobile and have an alarm system to remind me of important things so that I don't forget. If there's something not important and not urgent, forget it, delete it, and do not even waste your time thinking about it. So time management is extremely important. Multitasking, I think we as women are very adept at multitasking, but friends, let us not do it at the cost of or compromising on accuracy. It has to be accurate as well as multitasking. There have been studies where they have found that too much of multitasking can actually reduce your efficiency. So we need to be careful regarding that. The next step is you are going to find obstacles in your path. And if you find a path with no obstacles, it probably doesn't lead anywhere. And I think Dr. Kakadia sir and Dr. R.C. Shah sir definitely will agree with me through their journey of innovativeness. If there is a problem that you have faced, there are 3 ways how you can actually face it. The worst thing is giving up. Second thing is, yes, you bounce back to normalcy, but the real adversity leads to getting even better than before. And that brings me to the topic which is my favorite, and that is called as anti-fragility. And I think the COVID times were a testament to this. For example, during COVID times, I took out time to learn more about financials, about investments, did a lot of interviews, bonded with my staff like never before. And I think each one of us also nurtured their own hobbies, spent more time with their family. So we achieved a lot more than what probably would never have in the last so many years when there was no COVID. Keep learning, keep growing. Life is a learning process, and today I think we have learned from our seniors what we have not learned in the last so many decades. Crisis management is extremely important. So if there has been, for example, an end-off in your hospital, you have to analyze what went wrong, prepare for it so that it never happens again. So your response in the recovery, how you deal with the patient, how you deal with the next case, and see that it never ever occurs again. Crisis management is something which we need to be very, very adept at if you want to be an entrepreneur. And COVID has also shown how women leaders are capable of handling COVID crisis much better. SWOT analysis is what all of us need to do. So you need to know your strengths, need to know your weaknesses. These are both your internal part of the organization. Need to know about the opportunities and never fail to grab an opportunity when it comes. It will probably never strike again. And the threats that you have to your own organization, whether it is through your own staff or through somebody from outside. So this is something which you need to regularly monitor. Always believe in yourself, do what you love and love what you do. So we as ophthalmologists have taken up this profession by our own liking, and it's our now moral obligation to take it forward. But always remember your roots, be like a tree, always stay grounded, keep growing, but know when to let go. By my own experiences, I started in 1997 with my mother-in-law, who was an ophthalmologist since 1972, and we had this 135 women staff whose true Nari Shakti, but it was a very, very difficult and a daunting task. When I started practice, I had my 3-month-old baby to look after. My husband was still in training. We had a lot of debt, and I had to jump into private practice with no other option of either fellowship or any other kind of higher studies. And it was very difficult to balance family life, social life. In fact, there was zero social life and a professional life. And for our women's staff, we developed our own roadmap, developed their own skill sets, channelized their energies and strength, and invested in their growth potential. But friends, it definitely benefits not only you as an individual, your organization, our patients and the society, and especially having women staff. All of us feel like women usually leave the organization because of pregnancy and because of so many other problems at home. But we have had staff who have stuck with us through marriage, pregnancy, and so many other issues. They are better team players. They use influencing skills rather than authority, better social skills, better communicators, more empathetic to our patients, and we have found that their EQ is really high. So that is why that special trend towards having female staff. And how the staff benefited was it boosted their confidence. They became decision makers in their own houses, became financially self-sufficient and independent, and got a respectable place in the society. Most importantly, we had created a ripple effect and a trickle effect. What I mean by ripple effect is their own sisters and friends they motivated them and inspired them to work, and the trickle effect, they saw to it that their own children got the best education. So women empowerment along with economic growth, but remember, as a woman leader, there are a lot of criticisms that you would need to face. It's not easy. Like, for example, a male could be called confident, but a woman could be called pushy or power mad for that matter. Women are expected to combine leadership with compassion and a dislike when they are not. Sometimes they may be feeling like they may be trying to promote themselves, but a strong woman stands up for herself, a stronger woman stands up for everybody else. So when you have a lot of women in your organization, each person is going to have a different pail, but a queen will always turn her pail into power. Yes, it is probably a man's world, but it's not a fight between men and women. All we want is a level playing field. All we want is to be given equal opportunities so that we have a harmonious relationship between us and make our society a better place to live in. Thank you so much for your time.
Children side now.
But this is one of the very truly inspiring. It's like in ophthalmology, after ophthalmology, people are taught to think out of the box. You are not just practicing ophthalmology, growing your practice, to develop your personality and other things. So really you have inspired everyone, including me, at this age.
Thank you, sir. Thank you, sir.
Many of them are actually an inspiration for both men and women, whatever the talk that I gave.
I call upon Dr. Srinivas Joshi to prepare for the next lecture.
Madam, you gave a lot of it's a very good motivational speech. In your experience as a woman, a leader or entrepreneur, how to balance the employees? Which one you feel that whether there should be more male employees in your organization or a female employees in your organization? Employees, doctors, all. And what are the benefits and
Sir, it's really not about having males or females, both are equally good. It's all about taking the right staff, and it's about handling them. Women are a little difficult to handle. They have their own problems, so you might have a female HR manager to handle so that they can handle their own. You need to be a little more flexible, for example, in their duties, or sometimes when they are absent for a few times for their personal reasons, because they take care of their own families too. But the most important criteria would be their skill set. It's not just because of female. If there are two people who have the same ability and the same skill, I would probably select a female.
Another thing, for sir's questions, you have mentioned woman-like thinking, you have mentioned. So if the woman-like thinking is there, whatever sir question is there can be solved. Woman-like thinking. That's what he asked. See, it is not male or female employees. You are asking male or female employees. See, what I want to add is woman-like thinking. So that can solve many of the problems.
To say for females, you should think like a female and male.
No, it is our thinking. It is our thinking.
Women think from the heart.
That's what. See,
That's what you are trying
So I'll give you an example. I know that we are running short of time, but just a simple example. Many years ago, when my husband was more into administration and all that, there was a staff who was not very good, and or had some problems. So when I asked him, how do you think I should deal with it? He said, just ask her to go. Ask her, don't come from tomorrow. I said, but she was a very good staff. She just had a personal problem. So I said, probably I have a different way of thinking. But I retained her. I supported her in that point of time. And today, she's taking care of my entire OT and entire, lenses and everything. And she's very, very honest. So it is all depends on how men and women react in a particular situation is different. That's all I need to say. I'm not saying men are wrong or something. It's not a debate here, but it's probably your way of thinking.
Yes, good afternoon everyone. At the outset, I would like to thank Dr. Kakadia sir, Dr. Shah and Dr. Satish Sheth for organizing such a beautiful event for the day. And since Dr. Anaga is my counterpart for ARC West, I have seen that there are few men working in her hospital, but she has not put the photograph. So next time what I will do is I will capture those photographs and put those photographs, because it was one time her driver who brought me and that driver is not there in this photograph. So the only thing is I have that liberty is because she hails from Dharwad and we both have fought elections for almost 6 years now, but not against each other, but of course she was representing the western zone and I was representing the southern zone. So anyway, jokes apart, so let me come to the topic direct. The topic given to me by Dr. Satish Sheth was how to make good videos. I would like to say not award winning but good videos. So I have financial no interest in this presentation. So it's always said that a picture says 1,000 words. In presenting a concept or a surgical technique, I think videos are of immense value and great teaching and the self-tool as well. So let's get started from here. So I've divided this topic into two, that is during the surgery and the post-surgery. That is how we have to divide the videos into two. So what are we not looking at? So now let's look here. The surgeon is operating, but the screen is somewhere else. So what is the surgeon missing here, or what are the learners or what are the observers not trying to see here is, it is not focused, it can be decentered. This is very, very important to have the TV just opposite to where you are operating. In one of the conferences, one of the senior surgeons from Shankar Netralaya said when postgraduate were asking that how to avoid the deflection of the light pipe in the vitreoretinal surgery and all those things. So I was giving some tips. Suddenly that senior, she's a senior surgeon from Shankar Netralaya, she got up and said, first you postgraduates or fellows should learn how to do surgery first and then think of all these fine focus and all those things. But I would like to differ a bit here, is because when you are learning, learn the best. Learn the good right from the beginning. My mentor Dr. Lam always used to say, whenever you do a surgery, you think that others are watching your surgery and do the surgery. Because it has a lot of learning value, whatever you are doing. Whether it's a good or bad, whether it's a complication, still there are some lessons which we can learn from each and every videos. So coming to the next, you can see here, of course this is just enacted, Dr. KP sir is here in this video. So you can see at the back, of course it was a little slightly physical challenge here because the TV was not able to fit because of the glass door there. So you can see here what happens there. again the assistant has to come and remind, sir, it is out decentered, it is out of center, please center it again. So these are some of the challenges which you will face if you don't see the TV and then operate, is because you don't know when the complication happens. And nowadays, most of the conferences, when I ask, they say, Srinivas, present a complication video. Present a complication video. So when you do not record these things, then how to present? You can't make a complication. You have to see what complication happens, you have to present it. So it's always important to look into this. Now, second thing is, yes, everybody are a good phaco-surgeon, good SICS surgeons. But area of interest, what you want to show. Now, if you are doing a chopping there, show the chop, show that fragment. Not just the phaco what you are doing, because everybody are good phaco-surgeon. But what makes you out of the others is where you are focusing. The area of focusing is very, very important. Now, look at this video. Now, you people tell me, I'll be showing two videos where the surgeon is operating. And if you see, of course, there is a decentered thing. The black you see here, there is no good light on this part. So proper lighting is also important. Whenever you are focusing, of course you are rotating, you are chopping and everything. But some part of the dark area, that will not give you a good quality of the video if you want to try to present it. So look for centration, focus, brightness and lightning. I think this is one thing which most of us will not concentrate more upon. We concentrate on centration, we concentrate on focus. We should concentrate on brightness. That is very, very important. The stuff we require, of course, the beam splitter, C-mount, preferred is original. Otherwise, definitely, Dr. Shade has done his innovation adapter. I think we have used in few of our microscopes. It's a very good adapter. You can definitely ask him. It's an innovation adapter, what they call. CCD cameras, whether you have 1 chip, 3 chip, doesn't matter. Sensor size, 1/3 to half an inch. These are the few of the samples, like having a good adapter and the beam splitter. And of course, a DSLR adapter is also available with a Zeiss, but it's very, very expensive. You can have a T2 mounted adapter for the Sony E mount as well. So the optical quality, I think, of the glass is what that matters. So it's very, very important to look into that. Whenever you're recording, record the full video. Later on, you delete it. If you don't have time, keep on buying the hard disk. Right? It's not very expensive. Now the hard disk rates are also coming down. But drape on to drape off. That is the video recording. Right? So post-surgery, you have n number of softwares. DaVinci, Final Cut, Premiere, After Effects of it. Keep the video short and concise because the audience have a very small span of attention. They easily try to get bored. So don't neglect audio quality. Voiceover is done, record it in a separate using the microphones or whatever you feel is best. Then people like action-oriented rather than idle and unimportant scene. Now if you see here, I'm just trying to do, the most important thing is not to fast forward. I've seen many of the authors, what they do is, they just to show that the complete surgery, they try to fast forward. So what happens when you fast forward, it looks like your hands are trembling, or it looks like there is a shaky video and all those things. So that will not give that much of importance here. So don't speed up the video unnecessarily. Now look at this video. My own video, I'll just show how did I try to speed up. So what I did was, this was again a bimanual surgery. If you have good fancy things like IOCT, use it, show it, so that it will be easy for the seat. Now this is a TRD. This is the cleavage where I want to go. Now you see that kind of disturbance, how shaky it is looking like, because I wanted to show the complete membrane removal, complete membrane segmentation, complete membrane delamination. It was not looking. Now let's look into the actual video, the actual speed. See, you don't have to show the entire membrane segmentation or delamination. You can just show the part and clips of it. But that looks nice, rather than speeding up the video and try to show the entire video. Now, if it's not necessary to always record in 4K, please remember that. Because in 4K, 20-minute video takes 1 GB. 3 minutes. Right? 3 minutes. So, it's very, very high, this thing. It goes on creating electronic garbage. So it's always important to, you can always do it in a small resolution and then you can convert it to a HD. And always I keep telling, add an emotional connect to the video. Add a personalized touch to the video. See, for example, if you are doing the resolution, frame rate, all these things have to be what format you want, BWF, MP4, MP3. So all these have to be looked into it before you are finally trying to export the video to the, see, this is the MP4, VMW, HEVC, AVI, so whatever format you want, I'll be coming why I'm telling this. So next thing is eye for the details. So guidelines for the videos. This is very, very important. So whenever you are submitting the video to any conference, look at the guidelines. So based on that, you can submit it. Some people say, I want 2D resolution maximum 1080, standard 720. Some people say that I want video bite rates as 5 Mbps. And so please note that 3D videos. So all these things have to be first looked into it and then submit your videos. That is very, very important. Then lastly, I want to say last 3 videos is use of animations, movie clips and copyright issue. This has become a huge thing. I don't want to say that, but I would like to say, because it's all ophthalmic fraternity sitting here, one surgeon from Maharashtra, he tried to put squint photographs. So one person from the other institute, he tried to, because there was digital marketing people who did that. This person was not even knowing it. And that person really banged him very hard. It went until the court as well. So what's the moral of the story? Use your own pictures, use your own videos. If you want to take as a copyright, please mention as a copyright that you have taken from that source, or you have taken from internet. Please mention the source, or you take a permission from that person only who has posted on the internet and put it across. But nowadays digital marketing, because it's given to the third party, all the marketing things. So they do not know what is correct, what is not wrong. But this was very ugly scene because 2 doctors fighting in this just for the reason of digital marketing, showing a pre-post squint of the child and trying to do that. Now, whenever we are shooting, even in the public, some people have come back and told, why was my child shown in that? Have you taken the permission of all those things? So the copyright issues has become a huge challenge. So please focus on that. There are few copyright videos available which you can freely use. Those are listed in the website. So those videos you can definitely use it. So now let's look into this. 2-3 videos I'm making. So use a lot of animation. Try to connect with that. So why I'm showing this helicopter going is because it's a dangling SFIOL video I'm trying to show. Now why I'm showing this avatar is because it was the case of retinal detachment, then PVR. So this is the PVR that tries to enter the scene. And then PVR strangling the retina. So you use the creativity. Please use your fellows, your residents, or they have a lot of creativity because they keep watching the Hollywood, Bollywood, Tollywood, Sandalwood, and I was in Dubai. They also said, what is that, Pakistan? Some wood is there, even Pakistan is also. Because most of the drivers in Dubai are Pakistanis. Huh? No. So the PGs, the fellows, they keep watching all these wood movies. So please use their talent. Now coming to the next. So this, just presented it in the last year ASRS conference. Sound please. So my colleague Dr. Giriraj, he said, sir, let's go Maverick scene, Top Gun. So it's like how the pilot prepares, sitting in the cockpit. So it's nothing less. When you are doing a surgery, you are also in the cockpit. You are also performing. Like you also need to have 6 Sigma rules, not doing any errors for your patients. See here, looking for the dangling IOL because the plane is just rotating. If you haven't seen Top Gun's Mavericks, I think today night you can go and see it. It's a beautiful movie. So use those things. This was a closed loop internal refixation was planned in this video. So it was a very innovative way of trying to do a vitrectomy and use the bimanual railroading technique of 904. Then use the other end of that and go inside the vitreous cavity. Try to bring out the suture on the other end, make another opening sclerotomy, use the ILS focus, bring it out and then tight under the flap. This got over just in 18 minutes. So some good technique, you can use it. There is no need to explant it and do it again. Now you see here, the dangling IOL was refixed and both were knocked together. So use some kind of these kind of innovations or anything of that. Last video, because Karnataka lovers, they love KGF. So try to connect with whatever is the popular movies, you can do that. So this was a 7-in-1 story of a blast picnic. So me and my colleagues, my fellows, everybody discussed what should be put for this. They said, sir, KGF has a lot of stones. They do a lot of blasting in the KGF movie. So let's use the KGF movie.
happened in this young gentleman, anterior vitrectomy. Why video is getting? So here the patient had RD with vitreous hemorrhage with multiple foreign bodies. Although the B scan, we could not count how many foreign bodies were there, but definitely we could assess it that there are few foreign bodies. So here the challenge is inducing the PVD in a detached retina. It's a very, very biggest challenge. But fortunately, everything was going well. Now this is our first look at the villain. Now you see multiple foreign bodies sitting on the retina. That is our villain here. So now, what you need to do? So this is called as the claw forceps, identified by Manish Pape. So here, catching hold of this bigger size contour, because these are irregular, this will not come through the regular forceps. So just IFB1 removed. There are multiple pieces here. So I just fast forward it. 2 removed, 3 removed, 4 removed, and then 5 removed. So okay, then I thought everything was okay, going well. But what hit me hard was there was again 2 more foreign bodies, which dropped after doing a scleral indentation again. So total there were 7 intraocular foreign bodies in this eye. But fortunately, we could save his vision. We could give a good ambulatory vision to him. And finally, what you have to do is end with a wow scene. Okay, so finally I will not say marks only for scientific content, marks for entertainment, his voiceover must look at these things whenever it's published on the website, because some people will not like using these entertainment videos as well. And some conferences they allow using the entertainment videos. So you need to be very careful about that. Is there social media likes or like audiences? Now the APO has started that if you want to win the prize, then you need to get the highest likes. So that's why I said I don't want to do it. It's better to stand for MP, MLA elections and rather than going around in the international conference asking people, please like my video, please like my video. I don't know why they have done that, but definitely, of course, they must have thought about it before doing it. But if it suits your consciences, yes, definitely you can go ahead and submit for those. But otherwise, please know the guidelines. That is very, very important. So take-home messages, a convincing and a concise take-home message will serve the purpose of keeping the message lingering in the mind of the audience. Okay, so I think I would like to thank all my fellows who keep contributing to these videos, whatever we are making. Dr. Giriraj Vibhute, Dr. Puneet is sitting here. I think we won the second ASRS Red Buckler Award when he prepared and he planned for it. So definitely you need a good team, I would like to say. I am just an operator, but whatever videos are being done and all these done, I give credit to my entire Vitreoretina department and all my fellows and postgraduates. Thank you very much for the patient listening. Thank you once again. Thank you very much.
Yes, sister, you can also become, you can try your hand in film field also.
Yes, try it. It's very nice, you are presented, and it's like hearing from a horse's mouth. It is true. Really, that's how you have won the prizes every year. But you have not given the secret how you win prize every year. Presentation, this will do it. So wish you more success.
Thank you, sir.
So just one doubt. We can record in 4K and compress it and put it in the...
Yes, you can do
so
that.
We can save more storage space and again we convert it back to 4K.
See, if you are very meticulous, punctual, then record it in whatever this thing you want and delete the videos which you don't like. But people like me, that I look once in a while, so I try to take more and more hard disks, but whenever you have free time, utilize that and delete the videos because they're just going to pile up. They're not going to look at 2019 videos. And if you miss that, you say, oh my God, something is missing. What if I have missed that video? So we don't try, Indian mentality, we don't throw anything. We try to keep everything. So if you are meticulous, then definitely keep deleting so that it will save your space and it will save the electronic ecosystem also.
Sir, convener sir, I would like to
next call upon Dr. Neha Dholkia. Neha Dholkia is IOL cutting tips and enforcements. Yes, sir. 8 minutes.
So first of all, thank you Dr. Satish Sheth for inviting. I have 2 videos. The first video volume. Hello.
Broken IOL complications have been the most dreaded for years. Dr. Neha Dholkia presents the IOL cutting tip and forceps. Broken IOL complications have been the most dreaded for years. We've been using techniques that are tedious and traumatic to the wound and the endothelium. The snare technique, which cuts the IOL into 2 halves. The twist and out technique, which requires a swift and skilled surgeon and can stretch the incision if not performed properly. IOL explantation through a cartridge, which needs force and can stretch the wound out. Crocodile scissors, which are bulky and cause rocking of the IOL and endothelial damage, and thereby getting post-operative striate keratitis and even a distance detachment at some time. Introducing this innovative tip, which makes it easy for any surgeon to cut the IOL extremely easily into 3 or even 4 or even 5 parts. Each sliver is only 2 millimeters in width and hence can be removed easily and gently through a 2.2 millimeter incision without stretching the wound or extending the wound at all. The reasons for explantation are broken haptics at the time of health, an unhappy patient due to halos and glare, especially in ringed IOLs, refractive surprises, dislocation or subluxation of the IOL. Now the tip is a stainless steel tip which is designed after many attempts to get the length, breadth, angle and sharpness right. The phaco probe has to be primed just as usual with the normal tip, and then the tip is removed and the IOL cutting tip is screwed in and tightened, and then over it the sleeve has to be attached. The forceps are such that the jaws of the forceps open and close vertically just like the mouth of a crocodile, but the grip is such that it is horizontal and open and close parallel to the ground between the thumb and the middle or the index finger. It is ergonomically designed for ease of use. The surgeon introduces the forceps to the sideboard and gets a good bite of the IOL. Then the surgeon positions the tip and simply presses on the foot pedal. The vacuum and aspiration are at 0, irrigation is on but low, power is between 20 to 50, that allows us to cut any hydrophobic or hydrophilic IOL with ease. As you can see here, the IOL is cut just like butter, so easily within 1 second. And the pieces can then be removed through the incision without extending the wound. This is an in vivo demonstration of the same. The IOL is being cut into slivers of 2 millimeters each, and each sliver can be removed without stretching the wound. The pieces have to be aligned parallel to the incision such that each piece can be removed efficiently without damaging any part of the outline. Advantages over the other techniques: can easily explant the IOL without extending the wound at all. There is no tilting of the IOL like with the scissors. There is no stretching of the wound. No special surgeon skills required. One can cut the IOL into even thinner slivers if the need be. All in all, this technique uses the ultrasonic power of the phaco machine and removes the IOL, respecting the posterior capsule, the wound, and most importantly, the endothelium. Thank you very much. nice presentation. Dr. Neha Tolakya presents IoT.
So, a lot of people I just put it up on one group and lots of people got it. So then I made a second video of how to use it. So I'm going to play that because a lot of questions will get answered because of this video.
10 tips before using the IOL cutter and forceps. First, to try with the cheap foldable IOL in vitro first before using it in vivo to get comfortable. Second, the power is linear, continuous like in Phaco 1 and not pulse nor torsional. Third, the right hand for right-handed people holds the probe and the tip cuts the IOL from the periphery towards the center while simultaneously giving counter pressure with the left hand. For in vivo, keep the cutting tip at the center of the AC where the space is maximum, as away from the endothelium as possible, and instead move the left hand with the forceps backwards towards the main incision, sort of as if feeding the IOL into the open jaws of the cutting tip. Simultaneous movement of the right hand forward and the left hand backward from the start gives the best results. 5. Can start with 50% power and go down up to 20% in steps of 10 to give maximum endothelial protection. Go with the least Phaco power your machine cuts with. 6. Aspiration and vacuum are kept at 0. Irrigation should be on but low to prevent turbulence in the anterior chamber. 7. In vivo, chondroitin sulfate is a must to protect the endothelium, keeping the tip as posterior as possible. 8. To keep the sleeve pulled back as much as possible to prevent tearing. Release any twists in the sleeve. 9. The forceps are made of steel so as to be strong. Other forceps may break as a good amount of counter pressure is required. The tip is titanium. 10. Cuts both hydrophilic, softer, and hydrophobic, harder IOLs. So the jaws don't open and close like a pair of scissors, but in fact, using the ultrasonic power, they just slice through the IOL. In industrial use also, this is a comparison between ordinary blade or scissor cutting versus ultrasonic blade cutting. The temperatures were tested at the tip, at the irrigation ports of a normal Phaco tip and of the IOL cutting tip. In both, the temperatures were found to be same between 22 to 25 degrees Celsius. Get a good grip with your left hand holding the IOL very firmly and then slide the right hand forward at the same time sliding the left hand backward. If you see the sleeve is intact, you have to pull the sleeve as behind as possible and release the twists and turns in the sleeve. You will have an intact sleeve, else the sleeve can tear. So counter pressure with the other hand is the trick. So this becomes like a fire extinguisher which you have in the OT. In case of emergency, it can be used. One can ETO the instrument and keep it aside, or one can have it autoclaved in their instrument box. I think all instrument boxes can have one IOL cutter. It's commercially available at iolcutter.in. Thank you so much for your patient listening.
Innovation.
One question. Can this chip be fitted for all the Phaco machines? Can this chip be fitted for all the Phaco machines, or does it require a
So we found there are mainly 10 Phaco machines in the market, mostly. There are 3 threads, there are around 4 lengths and 2 thicknesses, and all the machines are a permutation combination of these. So whichever machine you have, I need to know, and then I will give you the tip for that particular machine. Don't try to use one tip in another, you may end up damaging anything. And I have cut more than 50 IOLs on my machine, and because a lot of experimentation is going on since 2 years. And it goes very easily actually. We have to just try to keep, so 2 people did this. This video was released and a friend of mine, Dr. Santosh Gulchandani from KEM, he called me the next day and he said, Neha, I have a tip and I have a dislocated IOL and I need to urgently remove it. Patient is going back to Dubai. It was not dislocated, but there was a dent on it. So I managed to arrange for him and tip within 3 hours. He used it. Through 2.2, he removed the IOL by cutting it into 3 pieces. And next day, he sent me a picture of the cornea. It was crystal clear, 6/6 vision, no endothelial damage. And through 2.2 millimeter, without stretching the wound, he could remove. Dr. Saurabh Patwardhan also, he had ordered this. And one of his residents broke an IOL while injecting. And he too said, Neha, next day result was post-op excellent. So thank you very much for the innovation. He will put it up on his channel soon. So 2 other people other than me have used it, because I think in a lifetime one may have to explant either due to ring IOLs or patient unhappy or dislocation or in OT while injecting an IOL. So maybe 5 to 10 times in one's lifetime. If one has big practice like Dr. Anaka, maybe much more. But basically, we all will require this at some point in time. So one can just, how you have a vitrectomy cutter as a spare, this can be kept as a spare for the IOLs.
Thank you. I come upon Dr.
There is a barcode behind. If anybody wants to buy it, one can just scan the barcode. It opens up a page which you can fill in which machine, etc., name and address and telephone number, and we can give it. It is commercially available for 13,500, which includes the forceps and the tip and includes GST. And delivery is free.
So this year I attended ASCRS and I would like to present to you the highlights of what is forthcoming, what innovations are going to come in the next few years for ophthalmology, and they are very interesting. When I reached there, it was snowfall in Boston. It was very nice weather. My sister is a dentist in Boston, so this is our house in Boston, and this is my better half, Lifeline, my sister. And this was the 50th year ASCRS conference held in Boston Convention Center. This attracted my attention. This is a Cornell objective field perimeter. So this is a perimeter which does not need the patient joystick, but instead there is a very high frame rate camera which is inside the perimeter. And when the stimulus of the light is presented to the retina, the pupillary sphincter constricts. And what they found out was that in the area where the light is projected, the pupil starts constricting from that area first. So pupil also has a selectivity of the constriction fiber having innervation from 360 degrees. So they take the advantage of this. So the patient doesn't need to give the feedback, it is the pupil which gives the feedback. And both eyes are tested simultaneously. This is now commercially available in USA. This is the schematic diagram of the optic where there are 2 cameras which are monitoring the 2 eyes. And the present. So this is how the machine tracks the pupil. This is how the machine looks. And they did some 16,000 examinations and compared it with Humphrey perimeter, and they found it is at par for 30-2 and 24-2 programs. This is how the stimulus are presented to both eyes simultaneously, and tracks and monitors both eyes simultaneously. So it just takes about 3 minutes to do the entire perimetry. and the patient doesn't get fatigue. The only time where it will not work is if the patient is on pilocarpine. We have to make the patient off pilocarpine for some time. Or if the patient had traumatic mydriasis with angle recession glaucoma, there it will not be with the feedback. But if the pupil is swift and reacting, this is going to work very well. They said that this will be for demo at the next APAO and AIOS, which is a combined conference in New Delhi. They are going to have a booth there. This was another very interesting introduction which I saw. This is Lacrifil. It's a cross-linked sodium hyaluronate which is 7% in concentration. It is made by Nordic Pharma, cleared by US FDA, and it's now available in USA. This is a 1 ml containing syringe, and you inject the Lacrifil in upper canaliculus and the lower canaliculus, and it jams the canaliculus without any mechanical obstruction like the punctum plug. So for severe dry eye patient, this is an excellent office procedure. And the Lacrifil crosslinks each other, so the upper and the lower canaliculus are joined by that strand of the cross-linked hyaluronate in the lacrimal sac. So the entire path is blocked. And if the patient feels very much dry eye, then just little pressure here and a certain amount dissolves and comes out. So that's a very nice treatment. It stays in the lacrimal punctum and the lacrimal system for 6 months. So this has to be repeated once in every 6 months. It's just 5 minutes OPT procedure. You can be done under topical anesthesia. The cost of one injection, which can treat one patient both eyes, 4 punctum, is $100 in US. I don't know what it will be in India, but maybe around the same. But in that works. So it's much better than the punctum occlusion plug, temporary or permanent, because the silicone plugs, they keep on giving some fun body sensation. This is another interesting innovation which is coming. This is also for the dry eye treatment. This is Tyrvaya eye drops, which is Vanicline eye drops. So Vanicline basically is the first and only nasal spray. So you put the spray in your nose and it irritates the nasociliary nerve, stimulates the nasociliary nerve, and it gives the afferent signal goes, and the efferent signal comes from the brain to the lacrimal gland, to the meibomian gland, as well as to the goblet cells. So all the 3 layers of the mucin secretion are taken care of. Now it's very interesting to know that Vanicline is a drug which is anti-smoking drug. So somebody who is a chronic smoker and wants to get rid of the smoking, the secretaries, they put them on the Vanicline tablet. And how it acts, it's a nicotine analog. So it stimulates the brain in the same way as the nicotine will stimulate by secretion of the dopamine response. But the patient is made off the smoking and is given Vanicline tablet from day 1 to day 30. So for day 1 tablet, it is containing very high amount of Vanicline. Like the patient is smoking 8 cigars a day. And then every day the concentration of Vanicline keeps on decreasing. So there is an adaptation time for the patient. So in 30 days time, the patient will forget the smoking. So that is this drug. And they found that the side effect of this drug is an excellent lacrimal secretion, excellent secretion of the meibomian gland, and excellent secretion by the goblet gland. So from there, this company took the idea and brought it to the ophthalmology. And if you remember, in our old days, old Majis, in order to prevent the dry eyes, they used to use, there was a chimney, snuff mountain. So it's basically a very highly scientific purified snuff, you can say. And this was the side, yeah, right. So this has to be inserted into the nose, and it the area the most sensitive for this is the outer side of the nose. So the bottle has to be pointed towards your ear, this way. So this, according to presented studies, this seems to be an excellent alternative for the dry eye management. Rather than putting any kind of eye drops, just put the nasal drops and it serves the purpose. Second advantage, me and Asi, we took even these drops in our nose.
Twice a day?
Yeah, it's once a day. to be taken for 4 months, and then the patient can switch it off for another 5-6 months. Again, whenever they start feeling the dryness, they can start the course for 3 to 4 months. And since it's a nicotine analog without the side effects of the nicotine, you can even get rid of coffee or tea addiction. It gives you the same kick. So in the morning, if you take, you don't need to drink coffee or tea. Just 1 little drop in the, it's a spray. So just 1 liter spray, and it gives you good for 12 hours, more than that. Another interesting thing which I saw was a digital gonioscope. It's made by Nidec. So this is a digital gonioscope which has an auto tracking system. So you put the patient in front of the machine, and the machine goes, touches the cornea, and it has a gonio mirror which is having 16 facets. So it takes 16 pictures of the 360 degree of the gonio, of the angle, and then the prism rotates a little by half of it, so actually it takes 32 pictures. And this is how it does, and the digital clarity is 4K, and you can feed this image to a virtual reality glasses, and after that, if you move your head, you can see the entire angle structure as if you are standing in the antechamber and the iris being your capital. So this is a wonderful device which can help us tremendously, and it can even stitch the entire image and make the 360 around you into a single stretch view which you can zoom and pan and surf and see the whole structure. And it nominates that this is 1 o'clock, this is 2 o'clock, this is 3 o'clock, digital. So you know which picture is of 1 o'clock, which o'clock picture reference mark you get. Excellent image is taken of the MIGS implants or ankle foreign body or whatever. The cost, I ordered, the cost is 32 lakhs, but
when I went first time it was 15 lakhs.
Now it's 32 lakhs here, but I felt it very good to invest. This is wireless. This is very interesting. I think the moment this comes in India, most of the eye drops companies will be out of the business. This is a femtosecond laser which docks on the patient's cornea, and again it has the same digital camera. The machine selects the best spot where to treat, and it will go and fire the femtosecond laser on the trabecular meshwork, create a very nice window which is 700 micron by 300 micron, and one window will release the pressure by 10 to 12 millimeters of mercury. So you can do 1, 2 or 3 or 4 windows. This is the window created in the trabecular meshwork. One day, this is 18 months, and this is 24 months post-op. And this is the comparative OCD picture as well as picture. And as you can see here, the machine is not that big. It's a small refrigerator-sized machine. They said that it will cost around 1.5 crore rupees, but it can be owned by several doctors, and we can move the machine or keep it at one place. The best advantage is that this is non-sterile, totally non-invasive, and an OPD procedure. We don't need to open. It's not even micro-invasive, it is non-invasive. So this will revolutionize the glaucoma, surgical glaucoma treatment. You can make the patients off the drug immediately. And this was another interesting device. It's a saxophone-sized small handheld device which is containing the femtosecond laser for creating the capsulotomy. So you just hold it on the eye, it will suck the eye so the eye becomes stable, you press the foot press and it will do a capsulotomy. And they are doing this outside the OP when the patient is in pre-op. So one resident or one junior surgeon will keep on doing capsulotomy for 10, 15, 20 patients, and then the patient goes into the surgery. Because again, this is a non-sterile procedure, it's non-invasive. So this is also going to change. And this is also a small machine, not a very big size, so it is shareable. This is another interesting device which is coming up. It is Zeiss Mycore 700. You can go on the Zeiss website. This is an entire FECO machine in the handpiece itself. So it has irrigation control, aspiration control, power control. Everything is at your fingertip. There is no console. And this is driven by a USB charger. So the other end of the wire, you plug it into a USB charger, connect the irrigation set, and the aspiration tube will go into any plastic bag. And it works so well. Theoretically it is disposable, but practically it can be cured. And this is the video of it. So the irrigation on, it has the same thing, foot pedal 1, 2, 3, like finger pedal 1, 2, 3 position. First position 1, irrigation, position 2, ultrasound on, position 2 is aspiration, position 3 is let us see a surgery. This is a grade 4 heart cataract. Going to be around $200 for each. So it costs around 17,000-18,000 rupees. So you open one pack, 2 times surgeries, PTO. You don't need to invest in the console. That's the main point. And it
This
is
also part of it. This is also part of it.
Yeah. So the one tip is FECO tip, the second tip is irrigation aspiration, and the third tip is vitrectomy. So entry vitrectomy tip also comes by default. So it has 3 tips, 1 handpiece and 1 power motor. And everything is disposable theoretically, but everything is reusable.
No, how do you change the parameters?
They don't have any parameters which are showable, but we immediately grasp it by our tactile feeling that this is this much vacuum, this is. And the second interesting thing is that it eats the cataract by kerosene. So there is no chopping required, there is no dividing required, there is no grooving required. You just prolapse the half of the nucleus in the entry chamber, touch it, and it will keep on eating it, and you just keep rotating the nucleus. So it will just eat in a circumferential or spiral fashion. This is another interesting dropless cataract surgery is now on the vogue because nobody wants to put the drop for 1.5 months or 2 months in US. There are no caretaker like in India. दादा जी अकेले रहते हैं तो कोई ड्रॉप्स डालने वाला नहीं है. So this is an optic ring which contains dexamethasone and ketorolac. So you slide that ring on the loop of diol before you insert, then inject diol. So it remains in the bag. This is another Dextenza Extra Mini. So this you put in the lacrimal punctum, and it keeps on releasing dexamethasone and antibiotic into the lacrimal river for the next 2 months. And as it is also most of these patients will be having dry eyes, so this will help even from the dry eye point of view. You can put it in the upper punctum if the patient doesn't have a dry eye. If the patient has a dry eye, then put it in the lower punctum. And this is DexiCube. Now this is another interesting device. It's a liquid, but it's a very cohesive, very high surface tension liquid of dexamethasone suspension. So when you inject it under the iris, it forms a ball and it remains as a ball, and slowly, molecule by molecule, it disintegrates. So it gives the drug in the chamber for about 2 months. You can see the video here. See, you can see that ball which is formed, and it will not move. Even when you do hydration, it will not move. You have to put it at 6 o'clock position, and then it will stay at 6 o'clock. Now, in this we will see a little bit gets separated and formed. इसका बैटरी लो चल रहा है, इसका बैटरी लो चल रहा है, चार्जर लगा है. Could you see that second ball coming down? Right. Now, an inspiration taken from a smoking bird or puffing bird and a vortex cannon. We all have made these vortex cannon when we were young to create smoke rings. And we know the smoke rings, right? So the science of smoke ring is that you can, by controlling the parameters, you can create a smoke ring which will have an exact amount of drug of exact size. So this will be an ultrasonic device which is a drug dispenser. So the antibiotic and anti-glaucoma drug is filled in this. The patient puts the cup like this and presses a button. And there is a small camera which will record the central pupil. When the center of the eye is in the center of the camera, it will release a puff. So instead of drops, it will be dry smoke which will be going on to the cornea, which is containing the drug which is quantum enough for the anti-glaucoma property. So all the conjunctival complications and all the lead complications will be taken care of and will be out. So this technology of vortex drug delivery system, ultrasonic vortex drug delivery system, that's going to come in another few years, I believe, and that will change the way we treat and put the glaucoma drops. There are several companies actually working on this. Then this is an intracameral mimetoprost which is inserted into the eye through a paracentesis on slit lamp. This will remain in the eye for 6 months. So the patient is drop free for 6 months. It's 1 millimeter by 0.2 millimeters in size, and it is preloaded on a pen-like device like this. And it's an sorry. Right, so it's an OPD procedure. Paracaine, put speculum. This is Dr. Ike Ahmed doing. This is a 30 gauge needle. And a press of a button on the pen will, there is little pressure behind it. A small compressed nitrogen gas is filled behind it. So the moment you press, that nitrogen will shoot. Take it out. Now in this we can see it much better. It has an affinity for the trapezoidal mesoid structure. So it will fall and sit there and then it will not move. Now, can you imagine what is this? This is another interesting drug delivery system. It's a lumigan ring. This is known as lumiring. So this contains 6 months worth of lumigan, which is mounted on a thin silicone thread, and the size is. There are 4 sizes available depending on the fornix size or eyeball size, and you measure it and select an order. And it's put into the fornix on the slit lamp or even without the slit lamp in an OPD procedure. So this is giving the prost ring implemented for 6 months. So there were about 20 more new things, but due to lack of time, I have to shorten the lecture here, which we'll discuss someday in future. Yes, Education Hub is an interesting, very interesting conference to attend. Huge trade exhibition where you can see the futuristic technology, which is still not FDA approved, but it's going to become so. I request and earnestly invite all of you for the next ASCRS, which is going to be held in Los Angeles. Me and Satish are talking that come to Hollywood, because this is Hollywood ASCRS. And those who cannot go to USA, don't miss the 40th Asia Pacific Academy of Ophthalmology joint conference, because most of the things which we saw in ASCRS is going to be displayed, because that is also going to be a very big show. Thank you very much.
We thank all the speakers for making us understand that success is not just about luck, but it's about hard work, persistence and result towards the goal. And I thank Dr. Srinivas Joshi for a short crash course on filmmaking.
Now we'll take a moment to present mementos to Dr. Prashant. Dr. Persappa B. Dr. Pradeep. Dr. Sandeep.
Thank you, sir. We'll move on to the next session, number 6, titled Navagraha. Panel discussion including 9 esteemed speakers on multifocal versus progressive IOL.
As they say, a good discussion increases the dimensions of everyone who takes part in it. So I request Dr. Shravan Pandit, the convener of the session, to come over the dais along with Dr. Vijay Kumar Sajjanar, Dr. Pradeep, Dr. Deepthi Savaikar and Dr. Krishna Prasad.
I would like to call the panelists of this session, Dr. Jagdish Kakadia, Dr. R.C. Shah, Dr. Arvind Maurya, Dr. Sanjay Russell, Dr. Satish Sheth, Dr. K.V. Satyamurthy, Dr. Shivram K.V., Dr. Lakshman Dasar, Dr. H.M. Ravindranath. I request them to kindly occupy their chairs. I would like to hand over the microphone to Dr. Shravan Pandit.
Good evening. I think we've been waiting for this kind of an exchange of ideas. We already had didactic lectures at the podium, but now it's time to probably have a crossover, like to have all the people who have already had a lot of experience in autofocus pro, also new product that have been displayed from morning. So this is a time for all of you to ask questions and to get the practical and relevant points, so we can always extrapolate it in our practice. They will start with Dr. Sanjay because he is reading in the end. So you are the opener. Like
in
I am
KM.
surprised how they got these pictures.
Sir, this is all working behind the scenes. And this is his photograph.
I was a cricketer. I started my career as a cricketer. I was going to leave medicine and take a professional cricketer. One of my friend's father told me, in those days, Gavaskar is only one. Everybody cannot become Gavaskar. You think medicine is going to be a permanent thing with you. This may not last for long and you will not reach that level. So forget this, concentrate on medicine. I played all the matches except Ranji Trophy, all the grounds in Bombay. I used to play 2 minimum matches per week, bunking the medical college and going and playing for them. And after my MBBS completion, I stopped playing the cricket.
Dr. Kakaria sir, your take on work-life balance?
Oh, for me, I'm very lucky that most of my social life balance is taken care of by Dr. Ila, so I'm practically free for my professional work and for the development and research. So
I think your first love has been machines. Am I right, Ma'am?
My first love has been machines, yes.
Right? So they say one machine can do
If I'm
the...
not making mistake, I think he went for engineering for a short time.
He's done his LLB also.
No, I'm talking before medicine.
Before medicine.
And I was a rank holder in IIT. My all India rank was 27.
Wow.
Unfortunately, I took medicine. I should have taken that.
They say one machine can do the work of 50 ordinary men, but there's no machine which can do the work of even one extraordinary man. And I think both of them are so extraordinary, no machine can take the place of the minds of both of you. So it has been a big gain for all of us, and thanks to Dr. Satish Sheth and Hubli Dharwad Ophthalmic Association that we've got the privilege of listening to both of you. Dr. Asisha sir, this is something that I want you to listen to.
Good morning all. As wife of Dr. Ramesh Shah, since the time we have been together, around 40 years, I have witnessed his dedication to his field, that is ophthalmology. He has imbibed in himself all the good qualities since his initial years, like hard work, honesty, ethical practice, enthusiasm to work for the benefits of his patients. He is always ready to learn and explore new methods, doing research and application in his work. He has been relentlessly training students so that the future generation of ophthalmic surgeons is benefited. Till date, he has trained some 80 students. In his quest for improvement in his field, he has done some path-breaking innovations like Autofocus Pro IOL, OmniGlow Video Glow, latest being his work in raw kinase drops. In his whole approach towards his ophthalmic practice, he has patients' overall benefits. He is actively involved in the stock market as well, his knowledge in finance being like icing on the cake. On top of this, he has various interests like painting, cricket, writing, to name a few. Thanks.
I was an excellent painter also. The only thing I regret...
Not was, you are.
The only thing I regret today is I really wanted all of you to make big money, because every time when I have given the lectures on finance and stock exchange, I know at least 500 families have made profit of 1 crore and more. Each staff nurse has made a profit of 60 lakh rupees in last 1 year. We missed this time because
we should organize one CME only on this. I tell you all, one day he said, will you buy Astral Life? So I said, okay, fine. Then he explained me that Modi Sahib is going to make 13 crore Shauchalay for the rural population. So each Shauchalay will need a pipe, will need this thing, this thing, this thing. So next 4 years, these things will go very high. So the share which we bought at around 50-55 went up to 500, and then he said, now quit. So we go and get up. So that way his tips are phenomenal, and I would say his tips are so accurate that the failure rate of his tips is only 1 out of 99. 99 times you will make money, only 1 time you will lose. And that also he says that in this 100 रुपये में 3 रुपये का जो था.
When the first time I made the profit was, we bought Aban Lloyd at 50 rupees. Then there was a boom on this oil exploration. The rig charges, which was supposed to be $4,000 to $5,000 per day, went to 2.5 lakh rupees a day. 25 rupees, 50 rupees share which I bought, that time I did not have the money. So I bought only 80,000 shares, which comes to 16 lakh rupees. It went to 25,000 rupees in 4 years.
So any specific strategy that you would give as an advice to all of us, because we missed out on your talk, but if there's one strategy that you would advise all of us to follow?
Next part, for solar, whole world is going away from the crude oil. So any replacement of crude oil, like solar energy, wind energy, these are going to do extremely well. Water treatment is going to be a big deal for the next 5 years. Hydrogen, electric vehicle has already gone through now, it's gone. But solar pump is going to become a big thing. I purchased solar pump, Shakti pump at 200 rupees average. Today it is 2,700 and I expect it to go to 20,000 rupees. And next to 2 to 3 years, if I come back, I'll show you that it crosses 20,000. From 200 to 20,000 and 5% of the equity is lying with me. I started with a small amount, but you have reached this stage because of continuous, and it works wonder. The science in investment is great, and you are likely to 100% success rate. You have to just wait sometime. We waited for 3 years. We did not move on it. But last 6 months, 1,500 to 3,000 occurred in 3 months. It's a great science, and all of us are very intelligent. Once you learn these things, you don't need anybody. And 99% brokers speak lie. This is my point. They always speak lie.
Thank you, sir. Dr. Kakadia, sir, and Dr. Asisha, sir. I think it has been motivating for not only all of us, but your lives have also motivated your own next generation. So listen to what your daughter has to say.
To describe my father in a few words is impossible. He's a living legend of ophthalmology, professionally such highly achieved, but also along with it, he's such a great innovator, always looking for new ideas and new research. Whenever I call him or whenever he visits me here, he has something or the other planned in mind for a new experiment, new research, something or the other. Manages all of his businesses so successfully on this side, but also he's a great writer. He has great skills in architecture. He designed our own house. He is such a perfectionist. He goes into so much depth to the basics of whichever topic he chooses. Recently, he's been doing a great amount of research and lectures for no obesity and diet planning. But those are some of his professional achievements. Speaking of him in personal life, also he is the best and such a caring father. To give you an example, when I was in 10th for my board exams, he shut down his evening clinic just to give me all the time he can to help me study and prepare for my boards and make sure I do well in my career. Not only for us immediate family, but also for all of the even distant relatives. He's always present there, no matter what the needs, be it financial, medical, any emotional or mental support, whatever anyone needs, he's always present, and he's the backbone of our family. Again, there are not enough words to describe in such a short time span. He's a great man, and we're all so proud of you, and we love you.
Thank you so much. So I think when your children appreciate the kind of effort that you have put in, so it's not just we are running after our profession or our own medical research, but sharing and caring for your own family, and that family when it gives back to you, this I think it really means a lot. No, it's not just the family also, but you consider your students also as your family. I think both of you have had interactions with your students, and all of your students really about your both. The kind of effort that you have taken to train them So what difference have you found in the kind of students today versus say 10-15 years ago?
I have been training the students in Pramukh Swami Hospital. They are post-MS students. I have 6 students per year practically. And most of them are so poor in surgery. So we train it from the beginning, how to hold the knife. From that level, they'll do everything. They do everything, all cataract, they do glaucoma surgery. I call them at my private, give them a LASIK. Everything is done, basic except retina because I don't do that. And most of the, out of almost 80 students we have so far, and 6 are already there. All of them, they are doing extremely good practice. With one promise they give me, that if you want to give us a Guru Dakshina, which is called, you have to do 1 surgery per month free of cost. For the rest of your life, this is your social obligation. These are these poor patients who have trained you, so you should never forget that. You will never refuse a single patient because they don't have money. There might be some people who might misuse it, doesn't matter. But you will not refuse a single patient. If you don't do it, you are cheating me. These are the words and they are doing it. All of them, some of them are almost earning 5 to 6 crore rupees a year. But most of them are earning more than 5 lakh rupees per month. And all of them have created wonderful, at least those patients, they will not spoil the eyes. My social commitment is this much. They will not spoil the eyes. And in my life, I have never refused a single patient because they don't have money. Because I have learned from these poor patients.
Yes, absolutely.
So it is my moral responsibility to complete before I leave this world.
And this is something Dr. Jagdeep
Hello everyone, I am Dr. Atik Shah, an ophthalmologist based in Nashik. After completing my fellowship in cornea and refractive surgery, I began my journey towards private practice in 2019. In 2020, I sought to acquire my own CPR machine. When I learned that Dr. Jagdeep Kakriya, an innovator behind OmniGlow from Bhavnagar, has developed his own CPR machine. After reaching out to him for the machine, he did not only craft a machine for me, but also graciously allocated an operating room for my needs when I visited Bhavnagar for my machine's delivery. During this visit, I was captivated by the intricacies and innovation in his operating room. Dr. Kakriya patiently fielded my inquiries, explaining concepts with clarity and depth, like a mentor guiding his protege. Since then, till today, he has shared invaluable insights on cataract and refractive surgery, transforming my understanding about this discipline. His unwavering support and guidance were instrumental in establishment of my new hospital and also in acquisition of my own LASIK machine. Dr. Kakriya's distinctiveness not only lies in his expertise, but also in his compassionate and supportive demeanor. One particular instance exemplifies his generosity and mentorship. During my formative years, he generously gifted me his own topography machine when my financial constraint hindered my purchase. I take immense pride in acknowledging Dr. Kakriya's forthcoming recognition by Telangana Ophthalmology Society by Ovation Award. He is not just a teacher or a mentor, he is a role model and parental figure whose impact extends far beyond the realm of ophthalmology. Thank you.
So that speaks volumes, sir. You don't even have to say anything because I know you're a very shy person and you would never say about yourself. So one parting message from both of you to all of us before we conclude.
Just to add on the student side, many of my students are not ophthalmic, but they are engineering students who come and work with me to develop so many different designs of machines and optics. And I make sure that they learn the anatomy, physiology, ophthalmology to a level that they become, from engineer, they become a biomedical engineer. Most of them eventually get the job in Siemens or General Electric, and many of them have got the job. Recently one boy got the job in ISRO. So, passing on the education and passing on the knowledge.
Thank you so much, sir. And Azisha, sir, just listen to this. Please.
Hello everyone, I am Dr. Hemant Mehta. Fortunately, I am very close friend of Dr. Ramesh Shah. We call him RC.
Very few people know my name.
Is a family name in my house and among my old friends. He is thoroughly genius. I would like to share a few of my experiences with him, but then this video will go too long. But it's rare to find such combination in a single doctor who is a thorough gentleman, very simple, and always ready to help. He is truly empathetic to his patients. He is a combination of entrepreneur too. And one thing you all must know, that he had scored excellent marks in InterScience also and in IIT entrance also. So if he would have gone in IIT, he would have become an engineer, but he selected to go into the medical, he has become a doctor. So this combinations of engineer as well as the medical thing has a basic background in his innovation. And one who can do this is definitely an intelligent person. And he's always true to his patient. Apart from this, because of his super genius mind, he has got a phenomenal insight in stock exchanges. So many times he phones me up and tells me, hey, do this, hey, do this, this is going to appreciate, and everything has got a clear-cut understanding and clear-cut reasoning. I'll tell you only two incidences which will reflect his completely different style. You all must not be knowing that he is an excellent cricketer, a true sportsman. He has represented our hospital in various competitions. He is a fantastic fast bowler. And the best part is, whenever we have to meet with any challenge, he leaves the pavilion saying, let me go in and show them, and that's the fun. I remember a few matches, one of the match with GMC and other few matches with other hospitals, where he just went out and started smacking right from first ball, and the way in which we enjoyed match. So whenever I used to see Dhoni smacking all the bowlers the way for India, RC used to smack the same way, 4, 6, this, that, in no way, in a very short time, he used to turn the entire scoreboard and our hospital used to come winner. That is one aspect. The second, quite many times I asked him, hey, how do you pick up companies? He said, while talking to small salesmen, talking to small people here and there, keeping your eyes and ears open that what is the trend coming up in the market, and then exploring the detail behind it, you can easily reach to the baseline and you can pick up the shares which you are supposed to invest and which is supposed to go good. So you can imagine this genius is just not Pantuji. This genius is very practical, very intelligent, and he is a grassroots worker. All these combinations has made today's innovator RC. I am very proud of him, and I wish that in coming years, every year he should come out with some innovation in ophthalmology to take the branch to a different level. I am very much aware that he is coming out with so many gadgets which we all can make it a throwaway price and which can help the budding ophthalmic surgeons to set up the clinic at a very, very negligible cost and can serve people at a very reasonable cost. I wish that RC should keep on working like this for not only 100 years, but beyond that, and encourage all the ophthalmologists sitting here. Wish you all.
Thank you so much. I think we should give a standing ovation to both of them. And thank both Dr. Divices Pvt Ltd sir, Dr. Ashisha sir, Dr. Satish sir. Please come on stage. Entire Hyderabad Ophthalmic Association and KOS for coming out with such a wonderful program today. Thank you all so much for coming in large numbers and making today's program a huge success. And we dedicate entire day to both of them, all three of them in particular. So thank you so much.
Thank you. Thank you everyone for staying all through the program. Thank you.
Yeah.
Then we'll have if we miss the flight, we'll have a night session of Dr. RC.
I would like to thank today's guest speakers and all the delegates, those who have attended today's meeting. Thank you one and all.
This one is I know before
You also.
Oh, sorry.
So we met. We met at
yes, Congress have cases. आप उसमें आ जाइए electric boy there. Huh? Power off.